We have time to change.
We have time to.
Red color, you said.
They decided to have a red color.
But I got a similar one, orange. Our flag.
So, but we are seeing a red tie. So we
Red
are
tie,
having.
there you are having
That's
red tie.
great. That's great.
Red ties.
That's great.
See, Deepali is also, Dr. Deepali is also with red sari.
That's really lovely.
Thank you.
Thank you, Deepali ma'am.
Thank you.
Just talk to KD, sir.
We are live now, ma'am. We can start.
Wait 1 minute.
Hi.
Hi, Pragati ma'am.
Hi, ma'am. Hi, Parul. Dr. Sushma.
We were expecting you all dressed up and decked up in red.
Okay. Valentine's vibe.
Yes.
Correct. Yes. That was right. That was a good thought.
Just wait for 1-2 minutes. Dr. KD, sir is joining actually.
Good evening.
Sir, welcome,
Hello.
sir.
KD sir,
Welcome, sir.
evening.
Yeah, we can start now.
Diverse areas, not just what I had
Please
in
join. Everyone is joining. 5 minutes.
Where is Bindu?
you will graduate.
No, where is
Bindu will join. She's busy. She told me.
Acha, she's busy. Okay.
Start.
Actually, I
Parul,
couldn't
you can
get
start.
him.
Can we start now?
Parul, you can start now.
Okay.
Hello.
Should I start? मेरा दिल पुकारे आजा मेरे गम के सहारे आजा भीगा भीगा है ये समा ऐसे में है तू कहाँ looking for my dear friend can you please find out Dr. Yamini Kale today
I think she is there.
जो सनम आ गए आज फिर दिल लेगी अब इतना भी गुस्सा मत करो Here I am, superbly elated to co-host this web series with the always happy-go-lucky Dr. Parul Sauji.
Myself, Dr.
7 o'clock.
Dr. Sandeep is there. I'll keep him company.
Parul.
Myself, Dr. Parul Sauji, with my co-host, Dr. Yamini Kale, would be taking you further for this Just Do Hysteroscopy seminar. अब ये वैलेंटाइंस वीक है एंड इट्स ब्लीडिंग रेड ऑल द प्लेसेस तो कॉम्बिनेशन भी आज ऐसा ही है ना यामिनी मैम
Absolutely. Guess the combination.
It's fire and ice. So Valentine matlab red, which is very fiery, and hysteroscopy.
We welcome all of you to the last web series of the Indian Fertility Society with Vidarbha chapter in association with Nagpur OBGY Society. Sizzling Masterstroke, the 31st web series, Just Do Hysteroscopy.
And as does the name says, just do it. So it's like प्यार की कश्ती में लहरों की मस्ती में. That is what it is. प्यार प्यार से hysteroscopy. And it's gonna be all about hysteroscopy today. The journey of hysteroscopy. So love is not what the mind thinks, but what the heart wants. And we all should love our uterus. And here we are taking you through this journey of hysteroscopy. So myself, Dr. Parul Sauji.
And I'm Dr. Yamini Kale. We will be your MOCs for today's session. I would request all the dignitaries to join us for virtual Samay lighting.
पहले भी मैं तुमसे मिली हूं या पहली दफा ये मिलके लगा. That's the feeling which you get for somebody like her. Welcoming someone who makes you feel so much at ease, totally adorable, with a cute smile and innovative ideas. We welcome our president for Nagpur OBGY Society and secretary with our chapter IFS, Dr. Sushma Deshmukh ma'am, to give her welcome address.
Okay, thank you, Parul and Yamini. A very good, lovely evening to all. Today I am really getting Valentine-like feeling because all are decked in red, for today's Masterstroke series of IFS Vidarbha chapter with our Nagpur OBGY Society. Friends, this is our 31st webinar and the last webinar of IFS NOGS from 2021 April to now today Feb 2024. Though I am an ART person, that's IVF person, I love hysteroscopy art. That's mean ART. So this last webinar is dedicated to my Valentine subject, that is hysteroscopy. So just do hysteroscopy. It was, love at first sight. In 1990, I had the glimpse of hysteroscopy. And it was deep down in my heart that I will find it somewhere, sometime. So after patience of 13 years, again I saw it in Mumbai 2003 with Dr. Betoki. Then I was behind my love and pursued it and got it. Then the histo-valentines, many histo-valentines came in my life, like Dr. Osama, Dr. Sergio, Dr. Gubini, and many more, followed by many international and national histo lovers and valentines. And the story continues. 2010, 2014, 16, 18, and now 2023. Carnival after carnival, and love increasing and increasing. With also the global hysteroscopy, Dr. Sergio Chief is here, 2017, 19, 21, and 23. So, the people write love letters, but I written 4 love books for hysteroscopy and also dragged all in IFS and NOGS, which are all my Valentine organizations. And today I am here with mixed feelings. The tenure of IFS Energy ending on 31st of March 2024, and had amazing years with wonderful friends. So many friends I got, and I was thankful to all for supporting me every time. So today our chief guest is Dr. K.D. Nair, President of IFS, who is our Pitamaha Valentine and very much respected figure in the IVF in India as well as across the globe. Welcome, sir. Our guest of honor is Dr. Pankaj Talwar. He's the president-elect IFS. You know, he's Encyclopedia Valentine, a very friendly, brilliant, and admired academician. Welcome, sir. Our another guest of honor is Dr. Survin Guman, who is our secretary IFS at present. Beauty with Brain Valentine is in true sense very calm, gentle, and helping in any matter. Welcome, Dr. Survin. Today we are having two histo lovers, that is two histo Valentines. From the land beyond, far from India, but close to India with his Valentine heart. Our histolo brought us together and a genius academician, chairperson of GCH, Dr. Sergio Himovic. You know, his password I was telling is just smile and love hysteroscopy. Welcome, Dr. Sergio Himovic. Another amazing histo Valentine who is deep in love with hysteroscopy. From the academic capital of Maharashtra, there is a from Pune, there is Dr. Milind Telag. You know, with very loving, caring heart, helping, teaching, and revealing secrets of his love of hysteroscopy. So, welcome, Dr. Milind Telag. Today we are having Histo Valentine chairpersons who also are always with their love scope to see, treat, and this concept and the caring for the patients. So I welcome Dr. Deepali Shukla, Dr. Pankaj Mate, Dr. Ashwin Deshmukh, Dr. Shilpi Sood, Dr. Chaitanya Shembekar, and Dr. Manish Baheti. Now it is very important to carry this Histo Valentine program lovingly. And we have two sweet Valentines just we have witnessed, Dr. Yamini Kai and Dr. Paril Sauji. I also welcome the audience, friends, seniors and juniors for this Histo Valentine webinar. Lastly, my two Valentines will be forever my Valentines, Dr. Bindu Chimote and Dr. Pragati Kharatkar, who are backbone of our all projects. So just enjoy and just do hysteroscopy. Thank you.
Thank you so much, ma'am. I now request our chief guest for the day, Dr. K.D. Nair, sir, to welcome us and enlighten us with your words.
So you're muted.
Okay. Yeah. Good evening. Good evening, ladies and gentlemen. I bring you greeting from a whole IFS family, 4,200 members spread all over India. And I must congratulate Dr. Sushma Deshmukh for organizing this last webinar of her tenure. This is based on hysteroscopy. And I also welcome Dr. Sergio Himovic, who is a known hystoscopic, and all the other faculty who are going to participate in this webinar. Since I am speaking from another conference, I'll give my greetings to all of you, and I wish this webinar to be a absolutely fabulous success. Thank you very much, and please carry on.
Thank you.
Thank you, sir. I now request our guest of honor, Dr. Pankaj Talwar, to please say a few words.
Thank you so much. I think at the very onset, thank you so very much, Parul and Yamini, for being such lovely mic coordinators, master of ceremony. I bring greetings from IFS, and I'd like to say hello to Dr. K.D. Nair, and who's in Jaipur at this point of time. Dr. Sergio, a very warm good evening to you from India. So I think when I saw this report of the Nagpur chapter, I mean, this synchronization of both NOGS and IFS has done wonders. And I think it's perfect example of synchrony and collaboration, that what you have done, Dr. Sushma. You and Dr. Bindu have just done wonders. When I see the report which you have sent to me, 31 webinars in 3 years, means around 10 webinars per year. And the number is mind-blowing. I had to write it down. The number is mind-blowing. You have trained around 25,000 doctors all across the world. It's a huge number. I mean, 250,000 people you have reached in nearly 3 years. It's a huge number. Getting 10 international faculties for your meetings is phenomenal. I don't know how you manage it. I think we have to thank here Corona Remedies also for what you have done. And you just said that your tenure is ending. your tenure is ending, and it's the last web series you're doing with IFS. That's what I could make out. But for all the audience who are present here, I'd like to tell you that your tenure is never going to end. The people who are recommendations, they never fade away. So I'll just give you an example of a small example of Ramayana. I think all of you would have read this wonderful book called, a religious book called Ramayana. Can someone tell me who wrote Ramayana? Who wrote Ramayana? Any one of you?
Valmiki.
Valmiki. Hi, Bindu. How are you? So
Hi,
when
sir. How are you?
so when I've been just saying that Bindu just Sushma brought out that her tenure is ending now. So I just giving her one example which came to my mind. When the Ramayana was being written, when it was written and it was being sold everywhere in the world, I mean, sold means word to word publicity. So when Naraji met Valmiki, so Valmiki told Narayanji, I'm just bit all knowledge from internet, that please give an autograph for this book, very beautifully written book. Please endorse his book. So he said he read that, we saw that book, beautiful book called Ramayana, which you are all reading. He said that, but your Ramayana is not very, very nice. Go and see Ramayana written by Hanumanji. So Sarji, Hanumanji is one of our monkey gods in our country, and Ramji is our god. So then Valmiki is quite distressed. So he goes to Hanumanji and says, you have written some Ramayana. I'll go see that Ramayana. He said, I've not written anything. He said, but you have written something. Naraji has said, and it is better than mine. I have done so much of hard work, Sanskrit and all those primitive lipis, and your book is better than mine. I want to see that. He says, I can't even write. So I've written with my nails, and I have engraved 10 shilas. I think 8 or 10 shilas. Shila means a stone. It's called a Shila Ramayana. So go and see that Ramayana. I've written this. So when Valmiki sees it, he starts crying. He says, what a beautiful thing you have written in 8 pieces of tablet. They called it a tablet in that time. Not a tablet like what we use, such a big tablet. It's a small tablet which he wrote on the nails. He starts crying. Why are you crying? You become better than me. But how could you write it? Because you wrote for recognition. And what I did was for my Rama. So probably finding it better. But in case you're feeling so distressed, I'm going to throw my Shila Ramayana into the sea. And then Shila Ramayana disappeared. No one ever saw it. So Sushma, what you have done is like you and Bindu, like a Shila Ramayana. It'll never go from the world. And I don't think any chapter, I may be wrong, but getting around 250,000 people and educating them in historioscopy, getting so many faculties, and the way you both embroidered together in different colors, both NOGS and IFS chapter and the whole country together, hats off to you. So thank you so much, guys, and big greetings to the whole team from NOGS, from IFS, all the executive members of both the societies, governing council members, and thank you so much for joining us here. With this, hold it hands. Thank you so much for inviting me as the guest of honor today. Thank you.
Thank you, sir.
Thank you so much, sir. It wouldn't have been possible
Really?
without the support of our parent IFS body all the time.
IFS parent body supported us a lot every time.
Thank you.
Thank you so much, Pankaj sir.
And we look forward to more such encouragement and support from Dr. Pankaj Talwar sir in his very vibrant tenure that we are going to see in the next 2 years.
Surely, Bindu. Thank you very much.
Thank you, Pankaj sir, for those enlightening words. And I'm sure that your tenure would be as eventful as this one was. So like the way we have discussed that we are going to do this Just Do It hysteroscopy session today, which is this web series, which is all about hysteroscopy. तो अब वैलेंटाइंस डे की इतनी बातें चल रही हैं, तो हमें ऐसा लगता है कि जैसे लव साइकिल होती है, वैसे ही हिस्ट्रोस्कोपी की भी एक साइकिल होती है. लव साइकिल में जैसे पहले यू गेट टू नो अ पर्सन, इट्स लाइक बीइंग फ्रेंड्स. उसी तरीके से the first lecture is about basics and instruments in hysteroscopies.
Parul, excuse me, Dr. Survin is remaining.
Oh, so sorry,
please.
We did not see her logged in. That's why we thought that she's not there.
Is she there? Dr. Survin is there? I think she's not there.
Yeah, ma'am, she was not there. That's why we thought that probably she would.
Okay. Okay, let's go ahead.
That's okay. And that's okay, ma'am. Absolutely okay. तो जैसे एक लव साइकिल में सबसे पहले फ्रेंडशिप होती है, तो So the first session would be basics and instruments in hysteroscopy. The second stage, जिसमें प्यार हुआ, इकरार हुआ. So that is about relationships. So it is about advances in hysteroscopy. And the third session, जब मेरे सैया जी से आज breakup हो गया, it's about the problems which you face. So the third one is pain management in hysteroscopies. So this is how it would be today. And we would be taking you from here for this journey of just do hysteroscopy.
Dr. Parul, Survin has joined. Just let her speak few words.
Yes, ma'am.
Till now, I will just share my screen. Dr. Survin, are you there? Survin, we can see you are joined. No, we can see you, but it is muted, no? नहीं हो रहा है? Okay, yeah. I will just tell your best. You can just speak in a louder way. I will just make it. Okay? Okay, yeah. 1 minute. Survin is there. Hello, Survin, you can speak.
Yeah. So, I also want to congratulate both of you and your colleagues, Sushma and Bindu. You have done a wonderful job in your tenure. I think it is amazing, and what Pankaj said, the number of people you have touched as far as teaching is concerned is amazing. And I think IFS really appreciates what Vidarbha has done. And all the best to you for the other tenures which are coming. I don't think you would ever go, like he said. For us, you are a very important person and you will always be with us. All the best.
Okay, thank you very much. We'll start now, okay? Yeah.
Thank you, Suvreen ma'am. That was really generous of you to pass on those words. We also have our secretary, NOGS, Dr. Pragati Khalatkar ma'am. Ma'am, please enlighten us with a few words.
So much. Well, respected dignitaries and all the delegates who have logged in from IFS chapters. I am secretary of Nagpur OBGYN Society. It was such a wonderful journey to do with Dr. Sushma Deshmukh, who is president for this Vidarbha chapter of IFS. We have done so many activities and I am just observing the sizzling strokes. And today I feel so sad that this is the last stroke of this web series, and how enlightening this web series was and how interesting was to make those series. And the most important thing which I have gained in this series was I have gained a very good Valentine. Can you guess whom? Bindu Chimote. She was the person whom I have met on this sizzling series, and I'm really thankful to IFS chapter for connecting with Nagpur OBGYN Society, and the name of Nagpur OBGYN Society has reached throughout the globe because of this initiative by our president, Dr. Sushma Deshmukh. Thank you, Dr. Sushma, for doing so much for Nagpur OBGYN Society. Thank you so much and best wishes.
Thank you.
Thank you so much, Dr. Pragati. I reciprocate the feelings. I have also gained you.
Yes.
As a wonderful friend, yes.
Together in the same, two swords in the same cover.
Yes. Rare but true, two women together.
Yes.
Thank you, Pragati ma'am. Now for our very first session, which is on basics and instruments in hysteroscopy, we would like to welcome the chairpersons.
Shall I stop sharing?
No, ma'am, that's okay. I mean, we can do it this way.
It's okay, ma'am.
Okay.
The very first chairperson is a very renowned infertility specialist. She's a consultant and director at Shukla Advanced Infertility and Test Tube Baby Center, Akola. She started this first IVF center at Akola and delivered the first IVF baby of the region. She has been instrumental in a lot of conferences and has been a member of ESAR IFS, and she's the vice president of Akola OBGYN Society. We welcome our first chairperson for this session, Dr. Dipali Shukla ma'am. We welcome you, ma'am.
Thank you, Parul.
Our second chairperson for the session is Dr. Pankaj Mate. He is an advanced gynec endoscopic surgeon in Ahmednagar, Pune and Ahmedabad. He's the director of Radiance Center for Cosmetic and Aesthetic Gynecology He's a director of TLH training in laparoscopy and hysteroscopy. He has won several awards for laparoscopic videos in many conferences. I'm proud to introduce him as he has been my senior in undergraduate days. We welcome you, Dr. Pankaj.
Hi. Thank you. Thank you.
Pankaj sir, over to you to introduce our speaker.
Yeah. Yeah. Hello, everyone. Good evening, first of all. And there is actually no need to introduce Dr. Sushma Deshmukh ma'am, but still I'll do the formalities. She is director of Central India Test Tube Baby Center. She has been HOD of Obstetrics and Gynecology in Getwell Multi-Speciality Hospital and Research Center. She is chapter secretary Vidarbha IFS 2021 to 2024. She is president of Nagpur Obstetrics and Gynecology Society. Then she has organized 2 national and 1 international hysteroscopy carnival, which were massive success. And thank you, Sushma ma'am, for that. She is regular faculty for Global Hysteroscopy Congress in Barcelona since 2017. She has written more than 25 academic and non-academic books. Academic publishers were like JP, CBS, and Paris. She is conducting public awareness programs for adolescent, reproductive, and menopausal age groups. Over to you, Sushma ma'am.
Okay. Thank you, Dr. Pankaj, and all the chairpersons and all the faculties here. So, what we have decided to have this last webinar on hysteroscopy is very important. So, why it is important, I will let you know. So just accept greetings from Nagpur and the IFS Vidarbha chapter. 1 minute. So the topic, what we have decided, one should know hysteroscopy basic equipments and advancement, and how we can do the hysteroscopy is the pain management in the hysteroscopy during office hysteroscopy. So my topic, I am covering the hysteroscopy basics and equipment, which is very important. So though I am already mentioned, I am a IVF person or ART person. In my view, hysteroscopy is an endo-ART. There's an admirable, rewarding technology, as it has pioneered the process of endoscopic viewing of the uterine cavity with less invasive form of treatment. And you know, the step-by-step in present scenario, if you look at the hysteroscopy, it ranks as one of the topmost modalities. And before that, before starting the basics, we should know the philosophy of the uterus and the hysteroscope. You know, the womb, hystra is the word, a Latin word, and another is the hystros is the Greek. So it is a combination of the two, Latin and the Greek words. And it's the most dynamic and adjustable organ in the mammals, as we know, the place that all humanity evolved from. And in human, it's in full form from menarche to menopause. Under the influence of sex hormones, the uterus undergoes various changes from a small prepubertal size to a normal adult size, and in expansion phase as we experience during pregnancy. And on a lighter note, I always say, we should treat uterus very affectionately. We should consider as a person, because uterus being a female organ doesn't want to lose its beauty and curves. Even though it is having problems, why it should lose its beauty? Even though there are fibroids, malformation, polyps, hyperplasia, and blockages. So we are there to take care of it. So we should not lose the beauty of uterus. Secondly, what is the philosophy of hysteroscope? To view the hystra through the hysteroscope is like learning the philosophy of the hystra, that is the uterus. And hysteroscope is also designed in a delicate way to adjust the curves of the uterus, to occupy the space in the uterus without disturbing its anatomy and physiology, that you are going to witness in this webinar. That's why today's most of the hysteroscopic procedures do not need anesthesia. And you know, we always discuss 15 years back, hysteroscopy was an ugly sister of laparoscopy. Why it is like that? Because even I have seen many these conferences before 2010 or like that. There used to be only one session on hysteroscopy of 1 hour. No importance was given to hysteroscopy. But remember, nowadays, so many importance hysteroscopy is gaining because of this quality, and it is surgery is totally different. Because how it is different from laparoscopy? See, laparoscopy is also good. It has its own importance, and hysteroscopy has its own importance. And when we club together, it becomes a really blessing for our patients and for us. So in hysteroscopy, only one entry point. So all operating instruments pass through the same entry point. There are no more ports like that to help us. No luxury of assistant, no luxury of putting many instruments that can help the primary surgeon. Can't use another hand. As in laparoscopy, we know we use both the hands. It is only with one hand we are doing all the things. Time limit is there. We can do laparoscopy for hours, but it is not like that because of the chance of fluid overload. And it totally depends on good visualization. So that's why it is very important to discuss this entity when we want to plan hysteroscopy. So many of my colleagues or juniors, they ask me, how can I start hysteroscopy? It's a very basic answer. First, I always say you should change the mindset and there should be a beginning. You have to change the mindset because many people, they are afraid of, they are not getting proper distinction, they are not getting proper relation. So remember that from impossible to I am possible. This should be the mindset. Determination, motivation, inspiration, and you should be ready for upgradation. Then beginning, you should gather all the information like you are all attending this webinar. So, these are very much good information. Then the workshops, training to visit at various places, like I visited many places to upgrade myself, then organize a proper room. Then you should know the indications of hysteroscopy, selection, setup, and counseling and other things. Now coming to the first thing, you have to change the mindset. And now my inspiration. My inspiration was Dr. Bekerki, frankly speaking. When I seen him 2003 in Mumbai doing hysteroscopy, it was very amazing. Then my motivation, Dr. Osama. And now the Midas touch is given by Dr. Sergio, my very good friend from I had been to Barcelona in his hospital. Then I went to Israel also. So really, you should see doing office hysteroscopy by Dr. Sergio. Really, it's a blessing to watch his surgery. So that Midas touch was given by Dr. Sergio. So these two important person, really, they are given very much in my life. And the fourth one is Dr. Gubini, recently had been here. Really is also pure. So these all are very different person from different countries and all are having very different aspects. Then it's a beginning, learning, motivation, upgradation. You start disclosing mystery and revealing the magic. Then it becomes, simply learning and loving. So hysteroscopy is like that only. Now the second, you should know after the beginning, you train, then learn the indications for hysteroscopy and proper selection of patient. So the indication, now we can see the hysteroscopies for all age group women. But for sake of thing, what we commonly using for the abnormal uterine bleeding, because these are the most common patient, 30% in our OPD. Because plain DNC can miss around 30% of the pathology like polyp, myoma. So it should be hysteroscopy when you are getting report of ultrasound with the having polyp or myoma. Always do hysteroscopy, friends. It is very important. Then evaluation of infertility. I will tell you, I always do my all IVF, pre-IVF hysteroscopy is very routine for me in my center. I will tell you the reason in my next videos. Then Mullerian anomalies are there. So many polyps, submucous myoma, which will hamper the fertility. Even you can remove the proximal tubal blocks also with the help of hysteroscopy. Then the patient conceives an evaluation of recurrent pregnancy loss due to the common septum. Then the misplaced uterine, then the contraceptive device. Very nice, you can remove without injuring the endometrium. You can remove the copper T or any contraceptive device with the help of hysteroscope. Then prior to IVF cycle, I mentioned you, then endometrial cancer, you can have a proper look of that thing. That's why you can have a targeted biopsy. Localize that lesion, so you should not miss that lesion. Then in offsets, which is very important, the retained products of conception. Friends, remember this. I have been telling to each and every my webinar or conferences, it is very important. Don't have a blind curettage when a written process of conception. The patients are coming to me with the oligomenorrhea, scanty menses or the secondary amenorrhea. So this is very important message. Don't put a blind, the sharp curate and like that. And very important hysteroscopy really intrauterine adhesions. So remember all this important way. Hysteroscopy plays a very important role in all these conditions. Then you have to select the patient. As a beginner, always, normally also we plan hysteroscopy post-menstrually except suspected tuberculosis. Because in India, tuberculosis is very common. We have to plan it. If you are suspecting tuberculosis, try it the premenstrually so that you cannot miss this tuberculosis bacilli. Or then start with the simple cases like multiparous patients. Just as a beginners, it should be very much important for the selecting the cases for the hysteroscopy. Then evaluate that with the transvagal sonography properly to avoid the sudden surprises. It is my routine practice. Even the patient is coming with the Doppler report or anything, I always do transvagal sonography myself to just have the idea about what I am going to operate tomorrow, like that. Proper fitness is very important because sometimes we do get high-risk patient and the office hysteroscopy really boon. Because in last week also I operated a 75 years old lady, really very difficult post-menopausal bleeding, and already they were saying that they will do the directly hysteroscopy. There was a polyp. I removed that polyp and there are very much contraindication for the anesthesia also. So I could do in the office hysteroscopy. So you have to select the patient accordingly. You are the pattern of patient. So there are multiple studies also there. So selection of patient is very important. Then setup, another important setup of hysteroscopy unit. You should visit the centers who are doing hysteroscopy regularly. You should have proper training and then you plan your hysteroscopy setup, instruments and equipments, which is this is the main important concept of today's lecture. The setup of an office hysteroscopy, if you see, 3 important things are very important in outpatient or the OT. Good quality of equipment and optics, then comfort of the patient and surgeon, which is very, very important. We should always devote time for that. Then adequately trained and skilled assistant. Then coming to the good quality of optics, well-furnished room, hydraulic table or chair, it is which are comfortable for you. Then the mobile cart, which will contain all the things. Friends, whenever I had been to Barcelona or even Bologna with Dr. Gobini, I used to see what they are there in the mobile cart. See, in our area, this is different, but the instruments are same, but we can select accordingly. So you should study whatever the things are there, like recording system, light source, then the pressure pumps, what are they all are using, then you should form your own setup. Then instrument trolley like office hysteroscope 2.9 mm with 30 degrees, it is best for everyone. Your 70% job is over. It is a continuous flow operative channel with the 5 French scissors and grasser. Always keep one trolley ready, send another one with the speculum or because these are the very delicate, very delicate instrument, hysteroscope. So I don't to keep together all these instruments. Actually, the speculum is very rarely required. Very rarely. I don't use, but always it is ready with in my OT. So well-furnished room, whichever thing you can have a table also, no problem with the proper comfortable stirrups. This is very important. Then the mobile card, distension media. We use the normal saline as a distension media. Now it is everywhere across the globe. Everyone has turned up to the distension media as a normal saline, and we are using the bipolar energy. And histo pump or the endomat, which is very important, which allows monitoring of the irrigation. Initially, it can be very difficult to buy such an expensive set, but you can strive for the better instruments, and because it controls the flow rate and your surgery becomes very easier. And when you are using the Medex pressure bags initially in the stage, we also used it initially. So generally we require very minimal pressure that I will show you 40 to 50 mm to separate the walls, and we can go maximum up to 70 to 80 mm or up to 100. So we people work on very low pressures. Very important, this is very important point. Then we use high definition camera system with better resolution. Then the light source, we can have halogen, LED, xenon. Initially I had LED, then I upgraded to xenon. Now everybody prefer to use xenon. Recording system is very important. Over the years, I learned that each and every video should be recorded. Because I started in 2007. If I look back to my previous videos and now these 2 videos now I'm doing today, it's very, very gross differences there in the quality of image and everything. So you should know, and you should show to the patient. The patients are very happy to see the videos. In office, they can see it, but in India, many patients, they don't accept the office sometimes because they are very much scared of pain, and their family members are always with them. They wanted to see the procedure. So that's why generally we show this video after your surgery, which is very important. And the electrosurgical units, as we are in normal saline, the distension as a distension media, bipolar cautery is used when needed. Then the instrument trolley I used, I told you already, 2.9 mm 30 degrees Betochi is operative. I am using Betochi office stethoscope with continuous flow operative channel. Then the 5.3 or 5.5 mm inner sheath and 5 mm outer sheath. 5 French scissors and forceps, really these are very important instrument, and we can remove polyps, and we can do adhesiolysis. You can even do dilatation with the help of, because see, very basic principle I will tell you. If you just open the jaws of your scissors, it is 6 mm, forceps is 8 mm. So you know that this space is there when you're opening and moving it smoothly in a typically constricted internal os. So it is very important for dilatation also, negotiation. So you are not perforating, it is everything is under vision. Then the bipolar also is there. When you can touch small polyps, you can just touch it and cut it. Then the instruments on another trolley are like that, sponge holded forcing to gauze pieces and other also not enabler. It is needed, but is not needed. Then the mechanical instruments already mentioned, scissors, graspers, spoon biopsy forceps, and punch biopsy forceps. It is 5 French, which is 1.67 mm. See how smallest diameter we are using and how sturdy these are instrument. We are cutting the bigger polyp. I will show you how we are doing it. Then the electrical instrument like monopolar, very few people are using, but mostly the world is using bipolar, mostly than a receptoscope. There are various types according to 15 French to 26 French receptoscope, but the better is the 16 French is the lower size, because even the Gubin is having the 3 types like the 14, 16, 18. He recommends the 16 will be the better for the proper visualization, the proper operative surgery. So now he is the main mini receptoscope person. So this is also very nice instrument you should have in the armamentarium. There's a Gubini's mini receptoscope. So many instruments are there. So I will recommend you to have a initial 2.9 mm. That will 70% your job will be over. Then you can have this mini receptoscope. So your job will be very easier. Then the other are I'm not comparing with the monopolar with bipolar, because other speakers, very nice speakers are there with us. So we'll move ahead. Then the proper cleaning of instruments, it's very important, because after completion of procedure, I still wash my stethoscope instruments. I don't allow anyone to touch, because these are very delicate instruments. You should wash with the water and detergent, then soft brushes, then the syringes should be used to flush the lumen, very important. And then you can use after tap water, you can use 70% alcohol for washing. Another is the 2% glutaraldehyde you can use for sterilization when you are having back-to-back procedures, like in workshops, and even in our hospitals, we are having back-to-back procedures. We soak these instruments with this 2% glutaraldehyde. But as I'm having 3 to 4 sets, it is not necessary, but still many times we can use it. Then another is a Betochi is indicated office stethoscope, but 2.9 mm is sufficient for everyone. Another important is dissection of uterine cavity. People ask me regarding the dissection of uterine cavity and the proper visualization, but friends, I will tell you, it depends on the phase of the menstrual cycle and the intrauterine pathology. So the proper dissection system is very important. So the training is very important, the good assistant, especially for the vaginal dissection, that you will require to close the vagina. Then dissection of uterus and continuous irrigation is very important for the panoramic view of the uterine cavity, as it opens the potential space of narrow uterine cavity, allowing the optimal visualization. But remember that this distant media can get easily absorbed systemically, compromising the patient's safety, which is very important for any hysteroscopist to have a limited time and use proper things for the proper place. So that's why we always say what is important. So you should remember that the 30 mm pressure is required to separate the uterine walls, okay? And 45 to 80 mm to expand the cavity, so you can do your work in a better way, and 90 to 100 mm for optimal visualization. So also distance depends on the phase of endometrium, the type of pathology, and the age of the patient. And you must know the intrauterine pressure should not exceed, if it exceeds more than 75, many times during operative, we need to exceed the pressure, but remember the time. You should set an alarm, and if it is more than, when you just remember, if it is more than 75 mm, retrograde passive fluid through the fallopian tubes occurs into the peritoneal cavity. So the abdomen pressure will be the below the patient's mean arterial pressure. And one should do the one important fluid dynamics. Why I'm telling everything? Because see, the You can see that these spiral arterioles, they run the crisscross, they are running perpendicular to the endometrium. You can see this. And through the crisscross uterine muscle. And what happens during gestation? These crisscross muscles open up and the pressure gradient is directly conducted from the cavity to the venous sinuses, spiral arterioles, and the intravascular compartment. That's why you have to be very careful. Higher the intrauterine pressure, the NMP, higher the absorption. So, especially in the case of myomectomy, there's a submucous myoma or the metroplasty, you should always remember about this thing, that the time constraint is always there and you should speed up your procedure. Again, more important, the absorption increases when there is a frequent release and distension of the uterine cavity. So you should avoid it. So we'll just have some basic things. Then the type of distension media I already told. The main, what we are using, the low viscosity electrolyte rich normal saline is we are commonly using. Now, commonly it is safe. I'm not again saying, but it is safe. But still remember, it doesn't eliminate the risk of CCF and pulmonary edema. So you have to conceal it. Suppose for patient is coming with submucous myoma around 3 cm, you should conceal the patient. Patient can have a two set of procedures, like the 2 sittings, because you can remove it in 1 sitting also, but sometimes there can be some problems, some cautery current is not working properly, some patient is not proper, that case is not proper. You should always counsel the patient or relatives that there can be 2 sittings. So you are very much free. If the time is exceeding, then you can stop the procedure, you can continue the next. There is no harm is doing like that. Now the distension system, there are very much things, they are mentioned in the books, like gravity fall liquid, then the pressure cuffs, then the 2 bags can be connected via connector. Initially, you can use this Medex bag, but then we should use the 2 bags and you can inflate with the blood pressure, but better that you should use the electronic suction. This is the main is the endomat or histomat, which is very important, and you should know the all settings. You can just see the normal settings they are given. It's a very primary thing. 75 mm the inflow, flow rate 200 ml per minute, and there is a given, there's a see everything you should know. It's a bar. Then what's the mm of H is the pressure, what is the pressure we are getting, and this is the flow rate. So you should have a watch on all these basic things, which is very important. And you should, before starting the surgery, you should be say that everything is in the properly order. Now after that, placing the all things in a properly is very important. See, you can see I have designed this like this OT table, mobile card on the left side. If you are plasma TV, that's not necessary, but you can put it if as a luxury item, and you can be in the front. Then your assistant or the anesthetist or the nurse or the surgeon, you are sitting over here, and your trolley is on this side. Okay. Then comfort of the patient and surgeon is very important. Position of patient. Correct lithotomy position is necessary, with legs apart, supported in a proper leg rest, with the buttocks at the edge of the table or few centimeters extending beyond the table. Back should be flat to avoid the post-operative back strain. And the no joint in the leg should be flexed over the 60 degrees to avoid the femoral nerve compression. Remember, this is the proper position. Now we are having the power lift stirrups also. Then the position of surgeon. We always forget about this. The surgeon should sit between the patient's leg. The eye level of the patient and the surgeon should match. Suppose some surgeons are in this prefer standing position, like Dr. Sergio is here. He will explain why it is important. Some are favor the sitting, favor the sitting position. So in that, we have to adjust the camera accordingly. Suppose anteverted uterus retorted. So your this complete system assembly moves accordingly. So again, there are so many questions, so many queries used to remain unanswered. There are difficulties in finding the correct instruments and handling it, entering the cervix and maintaining the glow to see the endometrial glow, selecting the distension media, adjusting the light source optimum, proper recording system, getting clarity of the image, sometimes minimum, maximum, so many ups and downs, but still, friends, just learn properly. So vaginoscopy is a non-touch technique. Just see what we are doing. Even then, there is no assistant. Simple vaginoscopy. We can see very nicely the external os, assemble the scope, introduce. Vagina is easily distensible with minimal pressure. No discomfort to the patient. You can see. And the appearance of the cervix varies according to the position and the axis of the cervix and the uterus. And the base time already mentioned, that's a postmenopausal phase. So inspect in a proper way, completely inspect the vagina. Then comes when I'm entering into the cervical canal. You can just see the cervical canal. See, it's so nicely you can see all the vessels, complete histology in front of you. Arbor vitae. You can see the blood flows very nicely to these vessels, the branches, and just move slowly, move with the currents, negotiate in a gentle way. The movement should be, the very precise movements. Go in a very patient with the patient, see the patient face, let the patient experience everything what you are doing. And at the level of internos, you have to turn in a right angle because this slit is a transversely oval or scope is vertically oval. So you have to move it in a right angle. Now you can see the right ostium. See, very clear picture. This is the typical, you can see the endometrial glands, left ostium. So this is how we do the surgery. So it is very easy to see. Now, so this polyp is a very small polyp. This patient was referred to me unexplained infertility. Hysteroscopy was not done previously. She had 3 to 4 IUI cycles. I told her because she was having the HSG report which was showing normal and she was around AMH is normal, everything is normal, not willing for laparoscopy. And 3 IUI cycles, she told me, I am not willing for other things. So I told you just we'll have hysteroscopy because on transvaginal ultrasound I saw during this typically proliferative phase during around 9 or 10 days, like disturbances in this endometrial lining. And the previous ultrasound reports normal. And when I started doing scopy, you can see this was a small polyp, very easy. You can just introduce the scissors. Proper, it should be the opposite of this, the notch. See, the instrument comes directly from the opposite of this notch. I'm cutting. See the very gentle cutting, very precise cutting. And always put a tag because it's a very small polyp. And you need to have this for histopathology. So remove it after the forceps, with the help of forceps. So now this tag is remaining. I'm going to remove with the help of forceps. So it won't lost in the water current. So after that, the next IUI cycle, I don't know, but the patient conceived and was very happy. This was a video of this patient only. So now there are difficulties. Why it is important in the IVF patient under this also? Because there can be flimmy adhesions, unexplained things were there. You are planning such a costly cycle. And at the 11th hour, you just can't say the patient that I cannot put the catheter. It's very difficult that the catheter is not going smoothly. So generally what I do the pre-IVF hysteroscopy. I'm having the notes on my side, whether it's acutely anteverted or acutely retroverted, or there is any difficulty, that I will let you know what is the difficulty. So sometimes there are difficulties. There's a flimsy adhesions are there. Sometimes there can be tough adhesions. If you can appreciate small tubercles are over there. So some things you cannot identify on ultrasound or even the transvaginal sonography, but hysteroscopy will give you the correct picture. Now this is the patient. Again, this patient was referred to me. Only one IUI was done and she's around 32 years old. Everything was normal. And always see the previous reports. Even though you were having a very big, very heavy OPD, always have that habit of screening the important report. 1 minute. So that you can better see that everything is in a proper way. So I just found one note. There's a difficult IUI. The IUI report was not there, but there was a difficult entry. So I convinced the patient that we'll do the hysteroscopy. And you can see what I found during the hysteroscopy. So we start with the vaginoscopy. Very narrow external loss, but you can negotiate with the water currents. Main water is the best thing. And where I was when I am now in the cervical canal, see, it was a very towards the left side. It is not in the center. And now what is important, see, what is there in between, see, this is a Nibothian cyst, which was exactly blocking the internal loss. And the IUI cannula must be hitting over that thing. Very narrow, this external loss also, even internal loss also, I had a difficulty in negotiating the internal loss also. So when I entered in the canal, you can see difficulty. I entered in the canal. See, it is not so healthy appearance. And there are small micropolyps are over there. I will show you the It is a typical case of chronic endometritis. And the treatment is very simple. You can give the doxycycline and the metrozil course. See, you can see here there are small micropolyps are there. See, that you cannot diagnose on your ultrasound. See, so that's why it is very important. You can know the direction of your cervicuterine canal. You can notice whether there is a stenosis of the internal nose, whether there are the internal pathology like this. So even sometimes I have seen some flimsy adhesions which we cannot appreciate on ultrasound also. Even I have seen the blockages at the level of the small polyps at the level of the proximal part of the tube. So which is very much diagnosed by the with the help of hysteroscopy. Now this is the recently I did this case, postmenopausal bleeding. You can see the ostium is completely blocked. So how I am doing, see, you can just appreciate. So I'm just putting the you have to be very precise while doing it. So just try to be very difficult to open, very tough. See, if some material was coming, some sticky material was coming from the cervical canal. It was very difficult to enter the cervical canal also. I'm trying with my scissors. This is the main instrument for her for dilating as well as the negotiating it. Now at the level of internal nose, you can see it cannot make out. Where is the internal nose? See, actually it took me 5 to 7 minutes to find out the internal nose. Every time I was trying with the help of scissor. This is an edited video. But it is everything is under vision, so it is very though it was difficult, but I could do it with the help of the scissors, and very nice. You can see very difficult to enter the canal also. I am doing giving the lateral cuts to enter the see. That is a picture. And now it is very difficult to take the biopsy also. What we do, we cut with the help of scissors, and then we take that biopsy part. So it is only inflammatory changes there. Nothing was there. And the patient was also around 70 years old. Nothing was there is no need to do anything for this patient. So this is how we take the biopsy. So it can be very easy with the help of hysteroscopy. So these are so that's why I always tell hysteroscopy is an endo art. In the 2 cells minimal invasive surgery, and it adjusts the curves of uterus, fits in the philosophy of the uterus. So every gynecologist should be aware of this wonderful art. So office hysteroscopy is a safe and effective option for diagnosing the management of the intrauterine pathology. Primary uses of hysteroscopy include the diagnosis of abnormal uterine bleeding, treating the endometrial polyps, septa, retained products of conception and adhesions. Upgradation requires proper training and instrument setups. Equipment selection should be based on all the types of procedures planned for the office or OT settings. And the appropriate patient selection is the most important component for both the patient and the physician comfort when starting on hysteroscopy program. Success of hysteroscopy procedure depends upon the surgeon, dedication, and the learning the updates. So I think still I am on the learning curve. Too many things to learn, so many heights to earn, lots of things to burn for myself, difficulties to churn. So the best will come from within. So learn and love and love. So these are my various books. Already told you, the people write love letters. I write love books for my hysteroscopy. So this is in Barcelona, and it was a bestseller book in Barcelona. You can see in the vicepress.com. These are my different books. And these are my global group. You can see the different, my friends are there. Even and now recently on 15th and 16th, 17th, we had a wonderful hysteroscopy carnival. You can see Dr. Luigi, Dr. Gobini, then Dr. Mario Francini, Dr. Osama, all were there with all national faculties, Dr. Pandit Pasar, Dr. Kalyan. So many people were there, and it was a very wonderful, successful conference. So I end with the famous saying by Carver: to everyone who wants to start with the hysteroscopy, start with where you are, with what you have, make something of it, and never be satisfied. So you should be behind your love every time. Whatever you like, because I loved hysteroscopy, I was behind that thing, and so that I could achieve so many things, and all my histolover friends are there with me. Thank you very much.
Thank you, madam. Thank you, madam. You have wonderfully covered the starting topic of basics of and instrumentation of hysteroscopy. And as Parul said, that we have entered the phase of love. We all are histo lovers, and really it was a great gift from you to have to listen your lecture on instrumentation of hysteroscopy. Madam, you have given very important guidelines and important messages to newcomer and important messages to change the mindset. Then one question regarding hysteroscopy, madam, because for a beginner, if he want to buy a hysteroscope, whether he should buy 2.9 mm or 4 mm, because sometimes in 2.9 mm Bertocci hysteroscope with Bertocci sheath, whenever we insert Caesar or grasper, there is a loss of pressure inside the cavity. And for a newcomer, it is very difficult to complete the process within short span. So what do you recommend, madam?
I always recommend 2.9 mm because for 4 mm, you need to have dilatation. If you do the dilatation of cervix and then put the 4 mm, then the complete histology has gone. If you want to see the uterus as it is, cervical canal as it is, then you have to put the scope in a very gentle way, and you should learn that art. So beginners also, I will always recommend that they should start with a 2.9 mm, and it should be the proper vaginoscopy without any without putting any speculum or putting any valcellum over the cervix, because once you put your main, you see the minute hemorrhages over there, and your picture has gone. Whenever there is a bleeding, you cannot see the picture properly. So that's the main problem. So that's why I started select a proper case. There's a multiparous patient, so you will be able to do then in a proper way. So I always recommend to have a 2.9 mm. Your 70% work will be over.
Right.
Okay.
Thank you. And how do you anticipate difficult entry in the uterus? Do you expect any patient to have difficult entry?
Sometimes a patient gives history. Suppose the patient is coming off intrauterine adhesions or with scanty menses after any curettage or the secondary amenorrhea. Definitely, we think that it is going to be difficult to negotiate with the help of hysteroscope. So you should be ready for that. Many times, others I have mentioned, always see the previous case papers in a proper way, because what happens, they keep a note that that my patient, they have given the note that a difficult IUI cannulation. So I was thinking why it was like that, because you may not see, even an ultrasound also may not see that it can be a difficult, but sometimes on ultrasound you can see the very skip lesions or like that in the intrauterine adhesions. In that case, you can suspect, and especially if you are suspecting tuberculosis, it can be a difficult, because there can be a difficult distension. What you are telling me, difficult distension, very difficult to see the things in a proper way.
Right. And do you use tablet misoprostol before?
No, because there occurs, I will tell you the reason. I have never used misoprostol because it increases the circulation, and whatever the things I want in my picture while doing hysteroscopy, that get lost. And remember, with 2.9, most of the things are possible. No need to put the misoprostol. There are studies, some studies are in favor of it, some studies are not in favor of it. But I'm not using misoprostol.
Okay, madam. And if you find large cervical crypt obstructing at the level of internal os, do you resect that crypt? Sometimes that is obstructing the entry in the uterine cavity.
Yeah, you're having scissors with you. You can just negotiate. Initially, you can just try. Initially, just remember, whenever I'm doing hysteroscopy, I just try with the water pressure. Water is a very normal, and is a very good thing that with the water you can enter the uterine cavity very nicely. You just increase the pressure, you will see that 70-80 times you can enter very nicely in the uterine cavity. If it is not possible, then you can use scissors of forceps.
Okay, madam. Thank you. Thank you, madam.
Thank you.
Thank you, ma'am, for the wonderful talk with your insightful tips as always. Parul, can you please share the screen? Moving on to our next talk for today. Now we've just heard the basics from Sushma ma'am, and all of us are very clear with that. So moving to the next step, as Parul had said, we are in the Valentine's Day love journey. So from the basics of meeting somebody and becoming friends, we are going on to a very firm relationship with hysteroscopy. And that is advances in hysteroscopy. And who better than Dr. Milind Telang can give us this talk. I have been fortunate to have done a fellowship in Galaxy, and sir is the main hysteroscopic surgeon there. We have all been inspired by him from the basics to advances, and he has given us great confidence in hysteroscopy. In fact, I started doing hysteroscopies after watching and learning from sir, and he has always been teaching and continuing to teach a lot of students. To chair this session, I would like to invite our first chairperson, Dr. Ashwini Kumar Deshmukh. He is a diploma in pelviscopic surgery. He is a master training in, he's done master training in ART. He's a director at Dr. Sudha Deshmukh Hospital. And he is currently the president of IMA Amravati. I welcome you, sir, to chair this session.
We like to invite the second chairperson for this session, Dr. Shilpi Sood ma'am, who is a young and a dynamic consultant, an IVF specialist at Safal Hospital and Diva Fertility Center in Nagpur. She has been a really dynamic person. We welcome you, Shilpi ma'am.
Over to the chairpersons for the next session.
Good evening, everybody. At the outset, I would like to express my thankfulness to IFS Vidarbha chapter, and in particular Dr. Sushma Deshmukh, for giving us this opportunity to be the chairperson for this session. Now, having gone through the basics of hysteroscopy, we are now at a position to understand the advances in hysteroscopy. And without taking much of your time, I request the next speaker, Dr. Milind Telang, to proceed with his talk about the advances in hysteroscopy.
Parul, you will have to stop sharing the screen.
Yeah, I'll just stop sharing now.
Telang sir, you can share your screen.
Yeah, I'll share it. Am I audible?
Yes, yes.
So let's go on to, at the outset, a big thank you to Dr. Sushma Deshmukh and all the fellow members and the board of IFS to have me here. I think you can see my screen now clearly. Yamini, is it?
Yes, sir. It is visible.
And I'm audible.
We can see
So
clearly.
I might take a little bit of time because these advances are happening daily in the field of hysteroscopy. And when I started my practice, I didn't know a word of hysteroscopy. Till 10 years down my practice, I learned what is hysteroscopy. And now in last 1.5 decades, I have progressed to a part where I'm giving you a lecture on advances in hysteroscopy. So it is always improved technology for better patient compliance and designed not only to diagnose, but to operate within the restricted cavity wherein the advances in hysteroscopy take place. So I'll just go briefly through the evolution and the concept. This was the person way back in 1805 created a Litch lighter, Philip Bonzini, for which this Litch lighter is still present with the Mercedes-Benz, which is still used. So he had such a big foresight that today also the same instrument is used. So this was the person who said, if the eyes of the fingers of the obstetrician have eyes, he will never err. And that is what he was talking about, throwing light into the abdominal cavities and the uterine cavity. And it took 60 years before which DC Pantanelli came up with the first hysteroscopy recorded, and he did it with a cystoscope, which was being used by Antonin, and he removed the first polyp. So this is a history, and from there we should know why we had problems. The delay was because we are in a cavity which is virtual. It is inadequate light transmission, inability to distend, and bleeding inside the uterus that takes place every month, which obscures the vision. So it was Professor Harold Hopkins with his brilliant brilliant way of changing the lenses from the old spherical to the long cylindrical, made vision absolutely possible. And today, whatever scopes are made of are known as the rod lens system. And no more, we have the fiber optic systems. Fiber optic gives you a pixelated image, rod lens give you a clear image, and therefore we are able to see very well. And similarly, there was Professor Lindemann who brought in carbon dioxide to distance. Sujimoto was the first one who used normal saline and who created an atlas for hysteroscopy from Japan. And then this person, R.S. Newworth, used the first resectoscope in unipolar current to do the first myomectomy. So it was the eagerness to operate within the cavity, remove the pathologies, and along with technical innovations that drove hysteroscopy. And today we are at an absolute place wherein we can call ourselves intrauterine surgeons. So this is what the progress hysteroscopy has made, and we should salute this modern day hysteroscope fathers, Jacques Hamu, who came out with the first 4 mm scope, the Hamu Endomet, which you are all using, and Stefano Bertocchi brought in the miniature hysteroscopes, the vaginoscopic technique, and he popularized the way office hysteroscopy is done. So from scientific curiosity to technique of clinical evaluation, it has now progressed to become the gold standard in the evaluation of endometrial cavity. So this is how I progressed as a resident, from where I went on to endocameras, then vaginoscopy, and then endo-C. So we have changed a lot because we have accepted what is known as innovations in technology. So change for good, change for the patient. We went from the regular operative theater to the OH, and this is because we can see from the regular scopes, the round scopes, we came down to the oval scopes, which Dr. Sushma Madam has already told you, from the old Hamu endomat to endomats for the office hysteroscopy. For the instrumentations, we came to the camphotrophy scope, which goes in naked inside, and whenever you want to perform, so it is just the 2.9 that goes in, and then when you want to operate, you can slide the sheath inside the operative sheath, which becomes 4 mm, and then you can operate. So what the purpose was to reduce the size of the dimensions of the scope. So a reduction in 1 to 2 mm causes a drastic change in the overall setup of the instrument. You can put in the inner sheath, the outer sheath, and the operative sheath, and therefore it reduces the surface area by nearly 50 to 75%. And these technical basically innovations drove us to a point wherein today we are able to do many things within the intrauterine cavity and prevent, I can tell you, we can prevent today hysterectomies. We went on from electrocautery to mechanical instruments. We had the 26 French resectoscope. We came down to the 22 French resectoscope. Now we have the 16 and 15 mini resectoscopes available. We also simultaneously went on from 2005 to mechanical instruments, or what is known as the shavers, which are MHTRs, mechanical tissue retrieval systems. The purpose was, we don't want any blind procedures within the cavity. We want everything to be seen and removed. So the philosophy was extremely good, and that is see and treat. Secondly, vaginoscopy, the non-touch technique, no speculum, no valcellum, no dilatation, so no blind procedures inside the cavity. And this was aided because of the oval scope, the 2.9 going up to, with the inner and outer sheath, 5.3, which adapts to the internal os, which is about 4 to 5 mm. So everything conforming to the anatomy of the uterus, we are able to throw in light within the cavity and remove the pathology. We changed for better from monopolar glycine, which was causing neurotoxicity, coma. We came into a normal saline bipolar, which is safe form of electricity, and therefore the complications decreased, making it much more safe, much more easily available for all the doctors and gynecologists to use this procedure within the uterine cavity. And therefore, we came up with what is known as the office hysteroscopy. Miniature scopes, normal saline, bipolar current, 5 French good instruments, and vaginoscopic technique. All clubbed together, we were able to get the patient outside the OR into the OH, that is outside for office hysteroscopy. And then this is the setup which we have at Galaxy, which we have done. which we have card, which is already shown by Dr. Sushma. We have an electronized table which carries the patient up and down, can give head low and a head up to the patient, and the entire card is set in such a way which helps you in performing ergonomically hysteroscopy. One word over here one should know is that endomat has to be placed about 10 to 20 centimeters above the height of the abdomen so that you don't work against gravity. And then we came to the next thing, and that is the mechanical tissue retrievals. Initially, it was only the TrueClear, which was developed by Dr. Mark Hans Emanuel from Netherlands. Subsequently, we have the MyoSure, and now we have also the Bugatti shaver available. Now, in recent, when I was at the ESGE, we saw many products which are disposable MHTRs produced by the Chinese companies. So they are 0 degree. They have a big length so that they can reach up to the ostia. They have different diameters, different window sizes, and they come in 4 variants. You have the 5C for office. The TrueClear 8 resembles as good as the 26 French resectoscope, where you might require dilatation, and the Elite Mini is 6 mm, where again dilatation is not required, and Elite Plus requires a dilatation of 8 Hagar. So these variants help us mechanically. So in this forum of IFS, when we are concerned with fertility, where we don't want, or we want to minimize current inside the endometrial cavity and damage and reduce the damage to the endometrium, these shavers are a boon for the infertile patient with a pathology. And they work in a very simple way. You have to put the window on to the lesion and start the suction and start the foot pedal, and it starts cutting. In a single insertion, the polyp is gone, the RPOC is gone. You can do a visual DNC. So everything is decided by the machine, the time taken. We have to only place the window on to the tissue. And you can see, depending upon the window size, what is the amount of tissue that comes out per minute. So from 5C, you have 8 cubic. When you use the Ultra Plus, it is 72 cubic mm. And all the tissue is collected for histopathological evaluation. So, and they found out, they worked with the resectoscope, and they sought to it that whether the learning curve is less. And they found out that only 3% of the residents could not complete the mechanical shavers, and they had to be taken up by the mentors, while in resectoscopy, nearly 17% had to be taken up by the mentors. So it has fewer complications as compared to the resectoscopy. Resectoscopy is an art. It requires proper training. And today, unfortunately, we have less people training it. And therefore, we have the shavers coming up in a big way, helping in removing pathology inside the cavity. It has many advantages: adequate tissue quality, complete removal, no damage to the endometrium, reduced operating time, less insertion, less fluid deficit, and can be used in office. And this was a mod trial which told us that this is just not a gimmick, but it can be used in practice. And definitely, I have already published a paper on the Indian study of shavers, where we did 84 cases in office and we successfully completed them. Vis-a-vis resectoscopy, you will see that the morcellation, it's only the contact of the window with the pathology, and how quickly the device can cut the tissue and aspirate out is already fixed. You have the RPM on the motor drives, and you have the suction. While here, resectoscopy is a surgeon that deploys each pass. You have to resect big. The pieces come in between you, the air bubbles come between you, and therefore it might take time. Sometimes initially you have to remove the resectoscope and again go in. The moment you do that, your vision decreases. So there is definite advantage of the IUM over resectoscopy. But having said that, we cannot do away with the pre-hysteroscopic diagnosis unless we know what is a pre-hysteroscopic diagnosis, and that is done by a proper 3D or a 2D sonography. We are not able to select our instruments properly. Whatever advances are done, clinically, we should be sound in properly selecting the patient for that particular equipment. Most important, especially when you're doing office hysteroscopies, you require counseling. You should know your patients. The banks do their KYC, we should do our KYP. Once we do, we should show them videos, and this is real time. You can see a patient undergoing morcellation. I'm not using a cap or mask. I have not changed into my scrubs. The patient doesn't have an IV line, and we are removing small fibroids, submucous fibroids with the help of morcellator. So you have a person to give vocal local, and you can see how easily we can finish a case in office. And this is because of technology. These are the advances which make it beneficial for the patient and helpful for the patient. So let's come to the different techniques of polypectomy, the advances. I'll run you through fast with these videos. So you will see different ways of removing the polyp. On both the sides, you will see one polyp is attached with a base which is small, and on the other side, you will find that the base is big. You can observe one base is vascular, the other is not vascular. One can be removed with the grasper, other will require a cautery. Now, these videos are fully available on the YouTube, so I will just show you the principle. Open the grasper, catch the pedicle, twist it, and push it, and you will have the polyp removed. And the other side, you have to cut the polyp base with the 5-French bipolar needle. All this is possible because of equipments in office without the patient feeling any form of pain. And this form of polypectomy gives immense benefit because you're not dilating the cervix. You are seeing and treating the patient and removing the polyp completely. So the polyp is gone. You can see how big the base is here, how vascular it was, and therefore we had to use current. So you should know the equipment at hand to remove such polyps. And they found out that it was Hinckley who found out in a large trial that 1,000 infertile patients scheduled for in vitro, the prevalence was 32%. So for all infertility specialists, you will see that polyps will be a big problem when you face, and it has to be easily removed. Here I am showing you a slicing technique. Maybe I'll show you in the next video also. When the interloss is closed, what do we do? Is there a way to remove? Yes, this video will show you. We open in situ with the grasper, and here you will see the MHTR for a big polyp. So how to retrieve the tissue? How equipments are made? Here I am using the bipolar needle to slice the polyp into different parts, one by one, and then I'll put in a tenaculum and remove one part. And over in the down video, you will see I put in the MHTR for a big polyp, and I'll just start morcellating it and remove it completely from the base. So two different techniques depending upon the instruments at your hand, but then you should be properly trained for these techniques and should undergo proper training, as Dr. Sushma Madam told you very well that training is important. How to use these equipments rather than just knowing the advances is very important. And both these procedures are done in office. Mind you, the patient walks home in 10 minutes and the tissue is available for histopathology. Then coming to the next pathology, RPOC. In this today's world, we have the Gutenberg classification, which tells you different types of RPOC. So 0, type 1, type 2. I will not go into the details. This is available, readily available on the net for reading. And therefore, with this findings up to 2, you can do with hysteroscopy and with the grasper, as well as, I'll show you, you can remove with the grasper as well as the MHTR. So it is possible to remove large RPOCs easily. And this is that each pathology can be tackled and you should not do any blind procedures within the cavity. So here you will see that there is a large RPOC and it takes quite time with grasper, because when you open the grasper, it is just 6 mm. So you have to do multiple times, you have to go in and remove. While on the other side, you are seeing an RPOC and you will put in a true clear 5C and it starts cutting and removing the RPOC, and in minutes, the RPOC is gone. So these are methods or advances which have helped us tackle different pathologies. Similarly, coming to myomas, and you have the traditional resection from the apex to the base, and here you will have histoscopic by tissue retrieval system, the 5C in office. So such a big myoma, 2 centimeters, can be removed in office by a tissue retrieval system. And where in upper video, you're seeing the traditional resectoscopy, which might take certain time and requires a little bit of patience, a little bit of learning and knowing of how to use the cautery well. Over here, we remove the myoma without damaging the neighboring endometrium. All the tissue is collected inside the cavity, inside the canister, and therefore you complete the pathology much more faster and in a complete way. So these are the different ways of tackling different pathologies by using the recent technology that is available to all of us. You can always use the hybrid technique. Here we will see that we are using the scissors to remove a small myoma, and then for a bigger myoma, we are putting in the HTRS system to remove the bigger myoma. These are all infertile patients, mind you. This was the patient who underwent embryo transfer 1 cycle later and then went on to have a proper full-term baby. So this is how we can remove by tackling the pseudocapsule properly with the help of scissors and removing. So it's not only the innovations in technology, but the innovations in technique respecting the pseudocapsule, which we have learned in recent times, which prevents any harm to the myometrium and less of bleeding, that we are able to remove a myoma. So this is just another way. You have to have all these instruments roughly initially when you start doing such cases in your armamentarium. And now we put in the HTRS for the same patient and remove a big myoma. So both the myomas removed in one sitting, and therefore we could have the patient for ET the next cycle. Then coming on isthmocele. Now increasing cesarean sections relate to this another pathology that is causing a niche which accumulates blood inside and then causes postmenstrual bleeding, endometritis, secondary infertility. And what better than the mini resectoscope? Without dilatation, the 15 French can go in, and you can then, as per the figure which I've seen, you can shown over here, you can cut the cephalad part, the caudal part, and align the cavity with the cervical canal, thereby preventing blood accumulating in that pouch and then helping for the patient to conceive. Another most important part of modern day hysteroscopy is evaluation of postmenstrual bleeding. Gone are the days when we said that hysteroscopy can cause problems or upstaging of cancer. So for this, first one should know how does a normal postmenopausal endometrial cavity look. Having said that, you will see the myometrial fibers, no endometrium, and this is how a normal cavity looks. And now you can see that as early as an EIN can be caught by just a grasper, by just seeing within. You see for the abnormal blood vessels by an office hysteroscopy, you can see some vessels here abnormal on this side. As you go, you will see that the endometrium is irregular. You go inside, try to visualize. You see the right ostia, left ostia, and then you can come to the other side. So this is one side where you will take a biopsy from, which you have already seen. And now you can see a small growth here, a protrusion. And this biopsy is very important. So targeted biopsies see and treat to helps in the pre-menopausal and the post-menopausal patients in picking up cases of cancer early and without upstaging the disease. And this is, we have already published this in the Indian Menopause Society, the correlation at pre and post menopause, the images of hysteroscopy and how hysteroscopy can guide you in diagnosis and how it correlates well with the histology. And here you will see a case of CA endometrium over here, clearly calcification, neovascularization, loss of arborization of the vessels, all clearly seen. You can also go and see that it arises from the fundus. And as you go down, you will see that the cervical canal is not involved, so helps in staging. And once you do an MRI and see whether it is involving the myometrium less than 50%, you know what is to be done next for the patient. We have, in fact, gone ahead and even said that we can morcellate or remove the CA endometrium completely, decrease the tumor load. And this is one patient, young patient with CA endometrium, wherein we could diagnose endometrium only diagnostically. We wanted biopsy only to prove the grade of the patient, because grading, if it is grade 1, we can give conservative management. If it is less than 50% involved, we can give conservative management. But if the grade is grade 2, grade 3, more than 50% involved, then there's no role of rather conservative management for infertility. So this is how we can use technology. And there are numerous studies now say that even a DNC, a bimanual examination, can cause dissemination. There was a meta-analysis of 5 studies, 756 cases, and they said that it doesn't. And FIGO has confirmed the same and said staging and prognosis does not alter. You have to just mention positive cytology that has been taken, and that itself is sufficient for us to know. Similarly, in the era of rising patients of breast cancer, we are giving tamoxifen, and tamoxifen given over a longer period of time causes cystic atrophy, polyps, and can also cause endometrium. And therefore, in symptomatic patients, postmenopausal bleeding, ET more than 8 mm, there we can perform office hysteroscopy and see to the endometrium, then take a biopsy and rule out endometrium. Not all patients require hysteroscopy, but all symptomatic patients, therein you have to remove the entire polyp, because we don't know whether the apex or the base of the polyp can have cancer, and therefore the entire polyp has to be removed. Similarly, another silent problem is endometritis, and Cicely was absolutely, he has given us the criteria wherein macroscopically we can say hyperemia, stromal edema, and micropolyps, as you can see in the pictures, can give a visual diagnosis. And when you do a biopsy by doing repeated implantation failures, you will see now this video. It's a big video, so I'll just go and show you the features of endometritis, how they look. You will find elevated glands, giving it a strawberry appearance. You will have hyperemia around the glands and stromal edema, giving it absolute pale stroma, and therefore the strawberry appearance. And here, if you take a biopsy, you should tell your pathologist to look for plasma cells. 3 to 4 plasma cells for a high power field will confirm the diagnosis. If you do a immunohistochemistry, CD138, if it comes positive, yes, it is definitely then endometritis, and it causes implantation failures. Here, simple, you can give antibiotics for 15 days, cynomycin or doxycycline. I also give estrogen progesterone combination for development of the basal layer, and subsequently we can see that the endometrial thickness improves and the implantation rates also improve. Then coming to uterine anomalies, now there is a different classification, the Eschere ASG or the Conita classification, which describes uteruses in different forms, that is for normal uterus, normal cervix, and normal vagina. And accordingly, we can use technology for correction of T-shaped and I-shaped uteruses. And here you will see how, with the help of 15 French resectoscope, without dilatation, you can correct a septum in a subfertile patient. You'll see both the ostia. This is the owl sign which is seen, and then putting in the mini resectoscope, you start cutting from the center and gradually keeping your eye on to the ostia on both the sides, from side to side, and gradually you can go up to the ostia and complete. Now this was as good as a complete septum, just falling short of the internal os and cutting in the same plane using, again, these are the advances. We can put in a Foley's catheter to prevent readhesions, do a second look after the next period, and then she is then able to conceive and take pregnancy to term. So these are different ways. Another important use is in correction of
This is a 36-year-old lady.
You will see that we can correct, and this is how we use sonography to find out whether it is a T-shaped uterus. And then with lateral metroplasty, we correct the concentric fibers, cut it from the kiphalate to the caudal part, falling short of the internal os. On both the sides we cut. We even correct the fundal indentation over there, and then again put in a pediatric Foley's, and you can see the volume increasing already in this patient. Do a second look for the patient, and you will find that the volume is increased, and we have already a series of 6 patients of dysmorphic uterus corrected in this fashion. All have conceived and are nearing term for their delivery. So advances in hysteroscopy for definitely improving the obstetric outcome in such patients is important for us. And how to use technology is to learn technology properly and use these equipments in a proper way to achieve success. Having done this, we should always report properly, because our fellows should know what we have done. And this is a standard report which I have developed, and we always give at Galaxy this report. Then these are publications which we have done to show both our Indian studies which are published, one for office and one for the morcellation. And this is, we have introduced our own way to tackle the cervical os, which is stenosis with MHTR. And this is also published with the ISGE, a video article which says how under vision we can tackle the stenosis and get into the cavity and remove the pathology. So all this can be done. You can see in this video a type 3 stenosis, which we open up by circumferential cutting and controlled suction and remove these fibers completely and enter the cavity and remove the pathology. So this is what we have published. So unless we enter the cavity, we cannot remove the pathology and cannot give the desired results to the patients. So using technology for potential benefits in the patient is important. And this was all done in office hysteroscopy. So the golden rules will be proper patient selection, evaluation and counseling, knowledge of equipment, dispersion of knowledge amongst the team, and a skilled surgeon. Thank you for a patient hearing.
Very nice.
Yeah.
Thank you, Dr. Thelen.
So nice.
Yeah.
Thank you so much. It is really eye-opener and mind-blowing. Really, really. I can see the you're being exploring from beginning, from the instrumentations and the past history and the approach for the hysteroscopy and many things. In fact, basic changes in the technology and adoption of the surgeon for these technology. And very best thing is the office hysteroscopic operative procedure is the best thing I could learn from this. And looking at the evaluation of gynecological cancer, endometrium approach, I just have a one thing still in my mind, whether it is really justifying, like saying like embryo biopsy, doing resection of the endometrial biopsy. So is there any fear of transmission of cancer and upstaging of the cancer? Is it there or not? That is there still in mind, and what is the real latest update? I really want to know about it.
Yeah, madam, there are two things that one should know. That it has been, the debate is going on for many years, but hysteroscopy with low pressure technique, when we are transmitting less cells into the peritoneal cavity. The cytology, even if it comes positive, there are studies that prove this cytology doesn't cause deterioration of the prognosis of the patient or upstaging of the patient, because these cells do not stay in the cavity for long. There was a very good study in wherein they did cytology and they found positive cytology. After 4 weeks, they found that the cells were missing completely. So these implants do not stay there and cause promotion of cancer inside the cavity. We should know the grade of the tumor. That is most important. So unless if the grade is aggressive, that is grade 3, it is more involving the myometrium, more than 50% involvement of the myometrium, then these patients cannot be for fertility. That is one thing. But if you say FIGO has gone into detail with this, and they have said that cytological stage 3A, but prognosis stage 1A. So you have to just mention, if you take a cytology and it comes positive, that you mention that. But if it is grade 1, less than 50% involvement of the endometrium and endometrioid cancer and mostly focal cancer, we have a series of 5 patients where we have done this. I have presented this at the GCH also in 2017, wherein we treated focal carcinoma in a 32-year-old lady Subsequently, we gave her high dose progesterones. The entire endometrium came out normal, and subsequently with only and only IUI, she conceived and took home a baby. So this is possible. Only thing, we should respect the grade of the tumor and the penetration in the endometrial cavity. And today, the advances are, we should know the molecular pattern of the tissue, that is the endometrium, that is more important. We have to do the P53 and all the pole mutase, which tells us whether we have advances in cancer. But these are all still in study. These are not implemented in protocols. Some people follow it. The cancer surgeons do follow it, but we should not follow it as of now, because there is a big study going on in Belgium, which will come out and then will throw light onto this. But till then, as a gynecologist, we can definitely evaluate the postmenopausal uterus with the histoscope and take a biopsy without upstaging the disease. That is for sure.
Actually, I will tell you, Shilpi, actually regularly, my husband is oncosurgeon. Regularly, I am doing histoscopies of such patients. And I will tell you, it is the question of the working with the low pressure. If you are working, see, already I mentioned in my talk, if your pressure is exceeding above 75, then it will go, there is chance of 2 fallopian tubes, it will go in the abdomen. Even though there are studies, but if you are working with the low pressure, because you can actually view what is happening inside, and you can take a targeted biopsy, as Dr. Milind sir already mentioned. So it's if you are working on low pressure, there is no problem, and there are studies that there is no such things are happening with the spread of cancer.
Yes, yes, yes. Thank you so much.
Thank you. Once again, thank you so much for inviting me.
Dr. Milind, it was awesome, very nice, wonderful talk.
Thank you, ma'am. Thank you.
Thank you, Milind sir, for that enlightening session. It was really, really something which took us through a lot of advances in hysteroscopy. Now, jumping on to the last session of today. And as we have said, that it's like a love cycle. तो problems तो आती हैं, breakup होने ही वाला होता है. तो to deal with that, we have 2 experts as chairpersons here. One being my mentor, none other than Dr. Chaitanya Shembekar sir. He's the past president of Nagpur OBGYN Society. He has been the chairperson for Infertility Committee NOGS and Emergency Obstetric Committee NOGS. He has so many awards and accolades to his himself, and he's a chairperson and MD at Omega Hospitals. We welcome you, sir.
Thank you, Parul.
And the next person is also one of the very renowned laparoscopic surgeon. He's a consultant gynecologist and a laparoscopic surgeon practicing for the past 20 years. He's the director at Shore Life Hospital and IFS-VC Center, Birdi, Nagpur. He's the managing committee member of IAG, and he's an ex-lecturer at DY Patil. He was an ex-lecturer at DY Patil Medical College. We welcome you, Manish Bhayati, sir.
Shall I start, Parul?
Yes, sir.
Yeah, please start.
Yeah. So, thank you, Dr. Parul, for the wonderful introduction. After nice talks by Dr. Sushma and Dr. Milind, now we have with us one and only one Dr. Sergio. I must thank Sushma. It is because of Sushma that we all are in touch with an excellent surgeon and a very good human being, Dr. Sergio. I got an opportunity to meet Dr. Sergio twice this year. Last when he came to Nagpur, and then recently at Bhubaneswar. And Sergio, you might not remember, but you were orator for our conference when I was president of Nagpur OBGYN Society. So it has always been a pleasant experience interacting with Dr. Sergio. And now we have, this is the last but not the least, a very important and interesting topic, that is pain management in histoscopy. And I invite Dr. Sergio for this talk on pain management. He is director of the gynecology department at Israel, and he is also the head of the reproductive surgery unit at embryo gynae clinic at Spain. and he has many publications to his credit. He is also director of the International School of Leisure in Gynecology at Bulgaria, and he is clinical assistant professor at the Faculty of Medicine at the of the Republic of University of Uruguay, and PhD in obstetric gynecology. That is something interesting. So I welcome Dr. Sergio, and Dr. Sergio, the stage is all yours. Thank you so much.
Thank you very much for your very nice presentation. First, I want also to thank my good friend Sushma Deshmukh to invite me to this chapter of the IFS. It's a great pleasure to be here. I hope you like my presentation. I'm supposed to talk about the pain management. I don't think that you will, if you do things correctly, as you heard from Sushma or Milin, you won't need to deal with pain during office procedures. But let's go into it and understand the topic. I don't have any disclosures here. I want first to bring you some definitions. What is hysteroscopy? Hysteroscopy is just a diagnostic procedure for the assess of the cavity. It's similar to the cystoscopy of the urologist. And I don't know any urologist that defines himself as a cystoscopist. So I am not a hysteroscopist. I'm more a surgeon of the intrauterine cavity. So intrauterine surgery is a procedure that we perform under direct visualization, but that requires a learning curve, skills, and we use, as you saw with in the presentation of Milin, we use many different kind of devices in order to perform this kind of surgery. So I define myself as an intrauterine surgeon. Now we are going to talk about the consensus. Until now, the Americans, they have one way of talking, the Europeans have another way of talking, and sorry, GCH is like a bridge between the Americans and the Europeans. So we came with international consensus on the terminology of these kind of procedures. So when we talk about the level of pain management, office procedure are defined until the level 3A. It means on no medication, or the use of non-sedative oral medication, or local anesthetic, or conscious sedation. It means that only oral or inhalation medication, no IV. The moment you move into IV, it's the level 3B, and it's not office anymore. So office is all these procedures that you can perform without anesthesia, all just local oral or inhalation, no IV. Let's talk about the innervation of the uterus, because if you want to understand the pain mechanism, we need to understand the innervation. So there are different kinds of receptors. First, we have the mechanical nociceptors, and those are the receptors that patients, through them, feel pain during the dilatation of the cervix or the distension of the uterine cavity. There are mechanical receptors in the cervix, so you cannot push the scope through the cervix because it will be extremely painful for the patient, and you cannot perform a sudden distension of the cavity because it will be painful for the patient. Then there are polymodal receptors that, again, they affect the distension of the cavity. Let's see the plexus that innervates the cavity. We have the hypogastric plexus, both the inferior and the superior. They are responsible for the innervation from the cervix until the 2/3 of the cavity, not including the fundal area. The fundal area is coming from the ovarian plexus. That's why when we perform a local anesthesia, paracervical or intracervical, it won't make total anesthesia of the uterus because we won't do anesthesia on the ovarian plexus. And it means that the fundal area of the uterus is still going to feel. So we need to use intrauterine fundal on coronal or coronal injection in order to achieve a complete anesthesia, local anesthesia of the uterus. You're going to see how I'm going to bring you a clear example of a case that we use this local anesthesia. And this is the case. It's a septum. So in the septum, it's in office without anesthesia. We started here with the scissors. You see, it's a fibrotic, the fibrotic tissue. So there is no pain there. She doesn't feel. And while we are going into the cavity, the septum becomes thicker and thicker. And it means that in the areas where the septum is thick, we are using laser key. There are innervation similar to the myometrium. So the patients start to feel pain when we are cutting here with the laser. That moment we stop. The moment she said she's feeling, we stop. We still need some area, and this is a needle. You see the needle? This needle is the Williams needle. It's a 5 French needle, walk through the walking channel. So we put lidocaine on the septum. Needle, it's very issue with the needle. And then we finish the procedure in office without anesthesia until we open the whole septum. See, this is the final result. So you can use also local anesthesia doing hysteroscopy. Here, putting something that you don't have, that's hyaluronic acid gel. So local anesthesia is something feasible also doing hysteroscopy. Let's talk about vagina. If you don't use the speculum, there is no problem. No women I know likes speculum. They hate the speculum. So if we can avoid using the speculum, it's great. So you use it by vaginoscopy. You see here, let me go. You see here these nodules that most probably are of endometriosis. They are inside the vagina. You can see here above that, you can see in a moment the cervix. You see the cervix over there. So the vaginoscopy, it's important to look at the walls of the vagina. Sometimes you can see some red areas that they can tell you that most probably there is an infection over there. So it's important to go and perform a complete vaginoscopy. The cervix, oh my God, the cervix and the cervical canal. So the problem here is the stenosis. We are all scared of having stenosis and how to deal with the stenosis. So let's go and talk about first the external os stenosis. There is no innervation. In the external os, you can use scissors and you can cut with scissors. This video, there is no external os at all. You see no external os. And you go with the scissors and you open the new external os. And the patient, it's office, no anesthesia. They don't feel because there is no innervation. Those patients are postmenopausal, and postmenopausal, the tissue is more fibrotic. There is no trophism, no homotrophism. So you go and you slowly open the external os with the scissors until you have enough to go in. Not to push, you can cut, no feeling, you push, they feel. So you have to cut enough to go through that without pushing, because we talk about the receptors that are over there, so you cannot push. You, as you say, you negotiate with your scissors until you have enough space to go into the cavity. Not enough here, you see? Open scissors usually is about 4 mm. Now we are inside the endocervical channel. There is this other case. Again, you have a stenosis over here. So when you cut at 3 and 9, and you can use also the grasper to open slowly, as you can see here, open slowly until you have enough space. Usually in premenopausal women, using the grasper is better than, and it's quicker than using the scissors. And you negotiate with the cervix until you have enough diameter to go with the with your scope. You here, as I said, in postmenopausal woman, use the scissors. They don't feel anything. You open enough until you have enough diameter, and then you just go in and they don't feel anything. What about the internal os? Oh, this is more also a problem when you have an stenosis of internal os. Look at here. But in this postmenopausal woman, the tissue is fibrotic. You can cut again at 3 o'clock, 9 o'clock, and they don't feel anything. But if you push, it's extremely, extremely painful. So you cannot push. You can open slowly with scissors, and if you have enough to go in. And remember that the stenosis is not only this small black area you see at the end, it's a conical area. So most probably stenosis starts before the end of this conus. So you have to open it slowly until you get enough area. And look, in perimenopausal women, you can go only with the grasper. You see, it's a tiny internal os, but you go not from this small tiny hole. You start before with the grasper. Open grasper is around 7 to 8 mm. So you have the open grasper, you have enough for going in, and you don't need to push. Pushing is pain, not to push, just to open. So you saw how to overcome this. Now we have to also to adapt ourselves to our cervical canal, to our internal os, and we are using an optic that's oval. So you cannot use it like this. You have to adapt yourself to the shape of the area you're going through. So sometimes you just put it horizontally in order to pass without touching the walls. Imagine that going through the endocervical canal is like parking a car between two very near columns. If you touch with your car the column, it will hurt your car. So you don't want to touch with the car. You have to go in without touching the wall. It's the same here. So you adapt yourself to the shape of the area you're going through. And we are using low diameter scopes. There are disposable scopes that they are very expensive, but we have also with office capital equipment that we are using, the Betoki. You have the Betoki 5, it's 5 mm. Usually in the Betoki, you have a 2.9 mm optic that go through internal sheath, it's the inflow, and there's also external sheath that's an outflow. I personally don't use the outflow. I only use the inflow. So I take out the sheet, and instead of 5 mm, I have my scope is 4.3. So it's a lot. 0.7 mm, it's a lot. So it helps me to go through without pain. I don't like personally the Betoki 4 with an optic of 2.1 because you sneeze on that optic and it breaks. And these optics are very expensive. And they put 2.9 of the Betoki 5. They are strong, difficult to break, so I prefer them. So let's talk about the uterine cavity also. So uterine cavity, it's like isosceles triangle, an inverted isosceles triangle, and we have two landmarks. In this case, the left tubal ostium and the right tubal ostium. So when we go through, if we move the scope because it's 0 degrees from one side to another, we are moving inside the endocervical canal, as you can see here, and it can be painful. But if you work with 30 degrees, your movement is only to rotate, because as you see in the picture here, when you rotate to the right, you are going to see the left tubal ostium. When you rotate to the left, you are going to see the right tubal ostium. It's the opposite. So it's very, for me, it's just much better to work with 30 degrees because my movements are very smooth, and the 30 degrees allows you to find any cutting plane of any pathology, even the fundal pathology you can find with the 30 degrees, and it makes your life easier during surgery. Let's talk about the myometrium. Myometrium is very sensitive to this tension. So the right pressure should be the minimum pressure that allows us the right visualization with the minimal discomfort for our patients. So not all of you will start with a pump. And the problem is that many of you will start with this, what you see here, the pressure cuff. And what people usually do when they start with the pressure cuff, they don't want to go pumping during the procedure. So before starting, they put a lot of pressure in that, and the pressure is very high. And when you go inside the cavity and you open the inflow, there is a sudden distension and very painful for the patient. So you must be aware of that you are working with this device that's very cheap. Just open slowly from the inflow until you have enough to see. You will see that you don't need to open it to the maximum. Sometimes, especially in postmenopausal women, it's almost closed. You need only some dropping in and you have enough. And another thing to take into account that this procedure must be very short. At the beginning, patients, what they refer is that they feel like menstruation, cramps that reminding the menstruation. But if the procedure becomes long in time, this feeling is will increasing and it will arrive to pain. I never arrive there. I stop always before. I have a dialogue with my patient, and when she tell me that the cramps are increasing and I haven't finished, I prefer to stop and finish another day than to make this a negative experience for my patients. Let's see how here from the we are going into the cavity. You see the external os. We are moving in and to the endocervical channel. I call it the coral reef, this area, because it looks like coral. And we are going to find another area with canals. This area with canals, and the name of it is Arbor Vitae, or Tree of Life. You see those canals here? This. So the Arbor Vitae is the Tree of Life. I call it the highways of the sperm. They help the sperm to go to swim, and they swim through these canals until they reach what you see here, the internal os. And then I'm showing this to my patient during the procedure, and she's looking at this video with me, and suddenly we are inside the cavity and she haven't noticed anything. So it's important for during the procedure. And when you are in, you look for your landmarks. So your landmarks are the left tubal ostium and the right tubal ostium. Okay, that's all you need to see. That's all you need to do. It's very easy. And all the videos you're seeing here are in patients in office without anesthesia. So I know that most of you think about this. If I do it in my office, it might be painful for my patient. What can I do if it's suddenly painful to my patient? Don't think like this, because what you're doing, it's a mental barrier. You're blocking yourself, and you are not going into office because you are afraid it might be painful, but it's not painful. We're using low diameter scopes, especially in parvus women, those who have normal deliveries. So don't choose a postmenopausal nulliparous woman for your first cases. Choose a multiparous young woman to do your first cases, and you will see how easy it is. They don't feel anything. You don't need to do cervical dilatation, and you go through that, and you see that it's not painful, and you will start to believe in yourself while you are doing this. And I think that the problem is not what they feel, but more this. I tell my patients that the problem is that they're afraid of what they think that they might feel, and the anxiety. The anxiety, it's a big problem during these procedures. So let's talk a little bit about the anxiety, because I'm not sure that what they feel, it's pain or anxiety. I know that when I'm going through the cervical and the endocervical canal, I mean, going near, approaching the internal os, so the fluid is going to the cavity and there is a distension, and they start feeling cramps, as I explained before. But they are so scared that they think it will be increased, and they are very tense. And that's why the anxiety is something that increases any feelings. Something small becomes big. And that's why I believe that we need to deal with the anxiety, because during this procedure, I won't say that there is no pain, because what if it's like a menstruation? Only a man can say that a menstruation is not painful. Women, they know what's a menstruation. So, but you tolerate that pain. And when you know what you are expecting, it's easier to go through that. So I believe the problem is anxiety. Let's see. This is a paper published in which you can see that anxiety represents a key element for the success of ambulatory hysteroscopy. The management of anxiety can reduce the request for analgesia with a consequent optimization of time, cost, and safety. So I really believe that our problem, it's not the pain, it's the anxiety. Look, another one. Women undergoing outpatient hysteroscopy suffer from significant levels of preoperative anxiety, comparable to those experienced before major surgery under general anesthesia. And this can have repercussion on the pain perception. The pain perception is increased by the anxiety. As you can see here, there was a significant correlation between higher scores of pain and anxiety. The higher the anxiety, the higher the perception of pain of the patient. So we need to know how to deal with the anxiety. And that's what we are going to do during the next minutes. So how can we reduce the anxiety before the procedure? We're going to see it before, during, and during the procedure. Before the procedure. To talk, to explain, to give the information, to explain the patient, as I explained to you, that what they are going to feel. I explain them that when we go through the endocervical canal, they won't feel anything. And the problem is when we get into the cavity, because there is no cavity. There is a cavity whenever there is a baby in, but right now it's like a balloon without air. It means that I need to put some fluid in order to see something. And it's very similar to what happened every month during the menstruation. During the menstruation, the uterus gets filled with blood. And what happens where the blood is in? The uterus doesn't want the blood in, so there are small cramps in order to put the blood out from the uterus. And that's why you feel it during the menstruation. And 100% of my patients, they say that they feel that, only that. And then I explain about the anxiety and how to deal with the anxiety. So to give information and to, have a balance of the level of expectation is very important. Another important thing, I tell my patient that the control is in their hands. I won't do anything without asking for their permission before. So they are very relaxed because they know I won't start before I ask them. And then I tell them that I never judge. I always respect. It means that even if I don't use the speculum and I go with a 4 mm scope into the vagina, it happens to me more than once, and the patient starts to express a discomfort. I won't argue with her about that. It's impossible because it's not a speculum, it's only 4 mm. I never judge, always respect. I will close immediately. No negative experiences. I always respect. And that's important to express that to your patient, that you always will respect, they will. And another important thing, and people, they usually don't think about it, it's about reducing the waiting time before the procedure. I don't know if you had experience going to the dentist. Remember the first time you went to the dentist and you were in the waiting room waiting for that, and the level of anxiety was increasing in time. And there is a nice paper that's in time we have a positive effort. It's easier. So you shouldn't let your patients wait a lot. Try to schedule them around the time they need to go in, and don't ask for a patient to wait 1 hour out there. And another thing that's important, they look at the faces of the woman coming out. So try to relax your women, your patient after the procedure. So when they go out, they go smiling, because it affects all those women that are waiting in the waiting room before the procedure. How can I reduce the perception of pain during the procedure? So we have different techniques: procedure technique, drug strategy, and non-pharmacological strategy. Regarding procedure technique, I ask this question: to sit or not to sit? I know that all of you sit down, but look at the picture on the top. The arm is in 90 degrees. It means that any movement this doctor performs is coming from the pectoralis, the deltoid, and the bicep. There are muscles moving. But if you see the picture when I'm standing up, I lay my scope on my hand and only move the wrist. I don't move the whole arm. So my movements are very smooth. And when you walk in office, it's very important. So if you can do a laparoscopy by standing up, that's a very long procedure, you can do this very short procedure also standing up, because I really believe that it's better for your patients. Regarding drugs, we say that the problem here, it's not the pain, but the perception of the pain due to the anxiety. So my question is diazepam. What I offer my patients, and I tell them that's negotiable, so they can say yes or no. I tell them that I personally take the diazepam in long overnight flights because it makes me relax and I sleep like a baby. And I tell them that it will make them feel like a zombie on a cloud, and only for the anxiety. It's not a painkiller. It's only for the anxiety. And I explained them that they cannot drive, that the effect of it's not the 5 minutes of the procedure, the 10 minutes, but it remains about 4, 5, even 6 hours. So they can decide, they know themselves. I don't know the level of anxiety. So they can decide whether they want or they don't want. Some they say yes, others say no. So if the patient say yes, and you don't want to wait a long time to the procedure, you just give them to put sublingual. And sublingual, it affects between 5 to 10 minutes. So until you have everything prepared, you will start and you will see the effect of that. So that's what I offer my patients. Another option is to use nitrous oxide. Nitrous oxide is the the laugh gas, and there is a paper published that you can use it during the procedure, so the patient can use the inhalation of that during and by demand. If she feels that it's a little discomfort, she can use it. Like women are using it in delivery room when they have contractions, and it affects immediately. It's very quickly, and it helps them. So it's another option. You see, it's compared to paracervical anesthesia when you compare what they feel using this. And now, non-pharmacological strategy. That's very important for me. We have two different kind of this. Everything is based on distraction. Distraction is the key here, because as I told you, when I go through the hysteroscopy and I put the attention of my patients on the screen, showing them the coral reef, showing them the tree of life, I'm distracting them. And when I finish distracting them, I'm already inside the cavity. And it's important. I don't know if it happens to you, but when I was very young, I used to go trekking on the forest, on the mountain, and sometimes when you got back home, you saw that you have on your on one of the legs a small wound that had been bleeding a little bit, but you didn't feel anything during this trekking because you were distracted. That distraction is very important for the perception of what they feel. And we have two kinds of distraction. We have the passive distraction. It means, as Milin said, the local vocal. It's a verbal anesthesia. The next here, you see her, she's with the patient, talking to her. Do you have grandchild? Then what do you cook? How do you cook that? And the patient is talking with the nurse, and she's completely distracted. And it's important. That's one way, and I like it very much. The other is the active. You can give a task to the patient, so she's concentrated doing the task, like using this ball and just push 10 times 10, and it makes some distraction. And important thing I always use is the music. Music is very important. And you saw that I changed my tone and rhythm of talking. It's important when you talk with the patients, the way you talk transmit also a way, something that helps them to be relaxed. So music is something I ask them. I tell them like this. I make a lot of tension. I tell them, my patient, I'm looking at her eyes and I ask her. I tell them, I need to ask you a very important question. Without that, I just cannot continue. She's very stressed. And then I smile and I ask, which music do you like? And they start laughing at me because they were expecting something very important, and I asked for the music. And all of them, they asked for the music. And it's important that they choose something they like, because if they choose something they like, it will help. You see, the music can be useful as a complementary method to control anxiety and reduce perception of pain. For example, when I have a Muslim patient, I let her, they choose prayers for the Quran, from the Quran, and they pray during the procedure, and they're completely distracted. And each one can choose what they like. And it's important. Another thing that's coming in is the use of VR, virtual reality. It's really coming in, as you can see here in the picture. This is a meta-analysis of a randomized controlled trials of the use of VR in the pain reduction during outpatient hysteroscopy. And you can see active VRT may be associated with a reduction in pain during outpatient hysteroscopy. So I think it may be the coming, because doing this, I don't know if you try that. I tried these devices. You are not only distracted by one of your senses, you are distracted by you listening and seeing, and you're completely in another place. Just it's completely different, because when you use music, you are only listening to the music, but here also your eyes are distracted, and it helps. That's another question that you might ask yourself. If I'm alone in my office, what if there is a vasovagal reaction? What it can be very severe. So I will give you, this is my classification for the pain during hysteroscopy. So there are two green flags and two red flags. So what's the level 0? Level 0 is less or equal to menstruation. That's what she expresses, and it's tolerated. And she asks you continue. That's a green light or green flag. Level 1. Level 1 is when the patient tells you that more than a menstruation, and it's very important, you don't see any objective signs of pain. She's not pale, she's not sweating, there's not tachypnea, she's not telling you that she's dizzy, no dry mouth. And she tells you it's tolerated, just continue, and you don't see anything, any sign of this. It's also a green flag or green light, and you can continue. Level 2. Level 2, and it's a level that in patients that they want to become pregnant, sometimes they are not responsible, because you see that like level 1, more than a menstruation, and you start to see objective signs of pain. She's sweating, she has tachypnea, she's pale. You see signs, and the patient asks you, please continue, don't stop. You have to be the responsible adult here. You have to take the responsibility, and you have to stop. Because if you don't stop, there's going to be a vasovagal. But if you stop here, you won't experience a vasovagal. That's a red flag. Even if she asks you to continue, don't continue. Objective signs of pain comes before a vasovagal. She tells you she started to feel dizzy. Stop immediately, not in 30 seconds, immediately. And level 3, it's level 0, 1 or 2, and she tells you it's not tolerated. So you must respect always. When she say no, stop, you must stop. Even if it's level 0, but she asks you to stop, you must stop. So if you follow this, you won't see any vasovagal during your practice in office. So let's jump to our conclusions. So for our conclusions, I just brought a paper published by us, Pain Management for In-Office Hysteroscopy, a practical decalogue for the operator. So we have 10 steps here. First step, perform appropriate pre-procedure counseling. You need the consent, but you have to explain, as I told you, explain to the patient. 2, assess the anxiety level of your patient. You have to reduce the level of anxiety. 3, if pain is not tolerated, you can use some drugs. 4, no pharmacological relief may be useful. So you remember, talking, distracting, everything. Train your staff properly. So you have to train your sister. She must be very empathic. You know that she likes to talk a lot, and she's empathic, and she connects with people. They need to know, everyone in your staff, what's their roles. Position your patient in the right position with an empty bladder. You need the pump, you need all the equipment, important. If you work with a pump, I work between 60 and 80 mm of mercury, low pressure. You don't need high pressure. You don't need. Use vaginoscopic approach. We talk about it. Use low pressure, as you see here, 60 to 70. Empty the uterus from fluid and debris while ending the procedure. If you empty everything, it will less cramps after the procedure, and you can let your patient rest for some minutes before she goes home. If you follow this, your patient will be very, very grateful. So I don't know if this video is going to work. It won't work. It's a pity, because I wanted to invite you, if you like these topics, I wanted to invite you to this, to HARTUS. HARTUS stands for H. It's hysteroscopy, ART. We talk with fertility, so ART is important, and US ultrasound. So we need to start working as a team between ultrasound guys or ultrasound unit, the ART unit, and the hysteroscopy or intrauterine surgery unit in order to increase our results. I already had 2 of these, a national in Spain, full auditorium, and we are doing this one now in April in Rome, in Italy. It's a pity. I think I can show you who is going to be there. So at least you are going to see this. These are the names of the people who are going to be there. They are probably you have only 4 from each area, but there are going to be 12 of the best in the world in each area in order to start working together and improve our perinatal results in our patients. And that's something that all of us would like to have. So thank you very much for your attention. I hope you like what I said and you found it practical. And if there are any questions, I would be delighted to answer.
Thank you, Sergio.
Amazing,
It
as
was a
usual. Wonderful.
wonderful presentation.
Thank you.
As you are mentioning about the standing position, you can explain that in a different way. How you can see that minimal pain for the surgeon, because the position of surgeon and this is very important while carrying out the hysteroscopy. So most of the surgeons, they are doing by sitting, but I think I have seen you by standing. So it makes, I think, very gross difference.
And another tip is never start with big things. Always start for very small things. In the beginning, only go there for diagnostic purposes. And when you feel confident in time, you will see a small polyp and you will ask yourself for the first time, what if? And you will think about removing the small polyp. And that's the way to start. You will remove the small polyp that you are prepared, and don't have 5 centimeter polyp at the beginning. Go with a some millimeters polyp and do the learning curve. There is no shortcuts. It's time and experience. And by that, you will become a surgeon. I cannot teach anyone to remove a 5 centimeters myoma. It's impossible to teach. I can teach you how to remove a myoma of less than 1 centimeter, because this is the one you are going to try to remove in your office when you do the first steps. And then going from simple to complex, it's up to you.
Anyone would like to ask any questions? Because there must be many queries or many questions, but you can ask. It's a good opportunity to have an interaction with Dr. Sergio Moish, who is the main coacher of the global community and a very highly academician, great academician. I think one point is also I would like to ask, you always mention content to this ratio.
About?
The ratio of this content to the container. That always you mention your talk.
The ratio factor.
Yes, everybody should know because it's very important.
Yeah, when we talk about fibroids or surgery inside the cavity, for example, the classification on LASMAR, the step W on fibroids, there are 5 items that all related to the fibroids, and you get a score according to how difficult it is. So for example, 5 centimeters fibroid gets a high score, and according to that score, you see if it's feasible to do it by hysteroscopy. You need to do it in another approach. So what we introduced is the ratio factor. It's the relation between container and content. It means that this 2 centimeter fibroid is different to do surgery in a small nulliparous cavity compared with a big multiparous cavity. So the same 2 centimeter fibroid is much more difficult in a small cavity than in a big cavity. And it's something that you also need to take into account, the room that you are performing surgery inside. And remember that nulliparous, the grade of difficulty will be higher than in a multiparous.
Nice. Thank you. Dr. Manish, you would like to ask anything?
No, madam, it was a very wonderful lecture and
Covered everything, all aspects.
everything.
Yeah, Parul?
Yeah. Thank you, Sergio sir. It was marvelous. And like the way you have been saying, heart is, so we are also giving a heart on this woman's health. It's all about that. So we, as gynecologists, I think the Valentine for us would be our patients, and we can do justice to them. And it's time to take time and, make women's health visible. So happy Valentine's Day to each one of you. Thank you all those who were in red, and thank you all those who couldn't be, because it's our little heart to all of you. So thank you so much. And we would like to invite the very vibrant, the very, very dynamic, joint secretary for IFS with her chapter. I always fall short of words for Bindu ma'am. She is exceptionally sparkling all the time, and we could just figure out this emblem for you. Now, sparkling always, and radiant as always. Over to you, Bindu ma'am.
Thank you so much for the wonderful introduction. I hope I can.
That's why I already told there are two Valentines in this thing, Dr. Bindu and Dr. Pragati.
Absolutely true, ma'am. And I feel that, definitely we look forward to the talks which are given by the experts. But the vote of thanks is something which we look forward to even more, because of the kind of, innovation and experimentation Bindu ma'am always does.
Yes.
Over to you, ma'am.
Yeah, just one moment, please. I think there's something wrong. How do I share?
Yeah, ask Piyush. Piyush, can you please help her?
I don't know what's wrong.
Ma'am, she's sharing her screen already.
Yeah, but I can't see my.
We also can't see the.
Yeah.
Ma'am, you stop sharing and you open
Can you
your
see?
PPT.
Yeah, I have opened my PPT. Okay, okay. Instead of minimizing, I just. Okay, just one moment, please. I'm so sorry.
And that's okay, ma'am.
Please be there to listen Dr. Bindu's vote of thanks.
That's the USP of all these talks.
Yes.
Ma'am, there is this share screen wala button.
I know, but I have opened my slide.
Now you share screen, and when you will be sharing screen on your main screen, you will see small icons of the things which are already open. So from that, click the PPT wala.
It's not showing. That's what I do all the time.
Sometimes it happens, Parul.
Yeah.
It's a Mac, Bindu. It's a Mac.
Yes, ma'am, Mac.
And it happens with Mac only.
Definitely.
And
I have
this
experienced it so many number of times.
Just a moment. What is
just send your this thing to Piyush.
Yes, ma'am, I can display, or ma'am, please.
Yes, that is a better thing.
Just close the PPT once and then reopen PPT, then share the screen.
Okay, I'll do that.
Please share your email also, so that by the time Bindu, you please share your PPT to Piyush.
Sure, ma'am, sure.
I have prepared really a good one, because
you just please share to Piyush, so that we are also.
I cannot share to him, ma'am. Ush, what do I do? Am I still there, or?
You are
You're
here.
there. We can see you.
Yeah. But I don't know where this. Oh. अरे यार. Hi. Hi. Basic, advanced. Yes, I got it now.
Yes.
I'm so sorry for this, but
No
I hope
problem.
you can see.
Yes, yes, we
Yes,
can
ma'am.
see now.
Well, so
Yes,
this is a special webinar today because it has to do with hysteroscopy. Hysteroscopy, I would say, is the heart of any ART procedure. And it is all the more special because, as Dr. Sushma has been saying again and again, this is my last webinar as in our tenure for us as secretary and joint secretary and for our team. Well, not last, we have much more to do as maybe ex-team members, and Sushma madam will always be there, of course. So with this, we had a wonderful webinar today on just do hysteroscopy, and what a theme to coincide with the Valentine's Day, which we'll have just in about a couple of days. So what is the measure of life but the distance traveled from the womb to the catacomb? So the love seed that arises from both Valentine's heart plants itself in the uterus, from where sprouts a beautiful flower. So, this is the journey and the story of the uterus that we have all been dealing with. And so, the uterus is the final stop of the internal journey. So, that is where, after that, the child will be born and will come out in the external world. But this, the womb is the last step of the internal journey. And so, it is such an important topic for us all to deal with. And so we can say that life begins here, and a hysteroscopic surgeon is the skillful gardener who prepares the ground for life to begin. So we are so thankful to all those who are associated with this craft of hysteroscopy. But then, especially, I would like to thank the three speakers here today, Dr. Sushma Deshmukh Madam, Dr. Milind Telang, and Dr. Sergio Hemovich. I would say the topics were basic, advanced, and management. Just like in love, you need to have your basics. You need to know what kind of a partner you are looking for, the basic requirements in choosing a partner, and then you make your advances on how to go about it, how to achieve, and how to get that partner as your life partner. But then to do all this, to maintain that relationship, whether it is a love relationship or any kind of relationship or any kind of procedure that we are doing, management is of most importance so that that relationship lasts for a long time. So basics, advances, and management, just as in love and relationship. Similarly, we have seen how beautifully all the three topics have been dealt with in terms of hysteroscopy, the basics of hysteroscopy by Dr. Sushma Deshmukh Madam. So beautifully delivered lecture where the simple points that we need to take home in practice were given by Dr. Sushma Madam. Then the advances in this field were given by Dr. Milind Telan. Thank you so much for giving such wonderful lectures. And a heartfelt thanks to Dr. Sergio for delivering such a wonderful lecture on management where it's not just about what the clinician, what the surgeon needs to do, but also how you need to take care of the patient's needs. That was really wonderful, where the patient, when what kind of pain she has, when she says no or stop, and what are you supposed to do, that is an important message that Dr. Sergio has given us, along with all the clinical aspects that have been dealt with. Thank you so much to all our wonderful speakers for such vibrant and lectures full of take-home messages. So thank you so much once again from the bottom of my heart. And then to chair all these sessions, we had wonderful chairpersons who, everyone has a heart of gold there. Everyone loves their subject. And Dr. Deepali Shukla, Dr. Pankaj Mate, Dr. Ashwini Kumar Deshmukh, Dr. Shilpi Sood, Dr. Chaitanya Shembekar, and Dr. Manish Baheti, thank you so much for being there and putting your heart and soul into this event and making it all the more livelier. Thank you so much for sparing the time for being with us today here. So in all these faculty here, whether the speakers or the chairpersons, they all have taught us how to do hysteroscopy, because the theme today was just do hysteroscopy, but how to go about it. So here's how to go about it. How to do hysteroscopy is what we have been taught today. Thank you so much to every single faculty who has been here. And of course, many thanks to the our academic partner, the parent IFS body, who have been the president of IFS, the Honorable Secretary of IFS, Dr. K.D. Nair sir, and Dr. Surveen Guman, who are in a very important meeting on poor ovarian responders at Jaipur, and yet from that event they spared the time to be with us here to give their messages. So many thanks to Dr. K.D. Nair, Dr. Surveen Guman, who were also the chief guest and guest of honor for today's function. So I mean, they are the heart and they are the heart behind our hearts that we put into all the events and webinars. And of course, we had also the presence of Dr. Pankaj Talwar. Thank you so much. He's the president-elect of IFS, and he is like a guiding light. Always ready with, I mean, whatever problems you might face, he's a ready reckoner. We can say he has answers to all the queries, and he's like a love genie. So all the practical aspects of life, or to deal with the subject of ART, every single thing. So Dr. Pankaj Talwar, thank you for sparing time and being with us today and encouraging by your presence. And of course, I mean, how can I not thank? We have Dr. Sushma Deshmukh, madam. So she has been the secretary of Vidarbha chapter. She has also been the president of NOGS, the Nagpur OBGY Society. And so wonderfully, I must say, hats off to her spirit, where she has managed both these. I mean, these are big organizations needing a lot of attention. So she has managed everything at the personal, professional front, her academics, her books, her chapters, everything. And so I'm really, really thankful to Dr. Sushma Deshmukh madam and Dr. Pragati Khadkar, the secretary of NOGS, for always being with us throughout all the webinars. And yes, the tenure might end technically, but we'll have long associations in future as well. So thank you so much, Dr. That was for Dr. Pragati Khadkar as well, ma'am. Sushma ma'am, you are very much here. And of course,
I'm always there with you,
yes,
but my tenure as a presidential is
I mean, no, it fills my heart with, I mean, I really was
I'm
teary-eyed.
always there. Don't worry.
Yes. So the masters of ceremony, Dr. Yamini Kale and Dr. Parul Saoji, I mean, we know how much you love not only the subject, how vibrant and vivacious both these girls are. Look at how they participate in everything. They are a part of all the organizations, social organizations as well. So Parul and Yamini, wonderfully done. Thank you so much. And you carried the theme of love and Valentine's Day too much. And I must say, I should specially thank Parul for always having 2 words extra for in praise of me. So it feels good. Whatever I may say, it feels good to receive such good words and praises from you.
I mean it from the bottom of my heart.
Yes, yes, I hope so too. Okay, so thank you so much. And of course, since we are at the fag end of our tenure, so on behalf of Madam Sushma Madam as well as myself, I would like to thank all our team members of, we were fortunate to have a 3 years tenure instead of the regular two years one. So 21 to 24, a rather nice, wonderful tenure, a happening tenure where we have witnessed 31 webinars. So many thanks to our patrons and mentors, Dr. Charulata Ranade, Dr. Natachandra Chimote, and Dr. Rohini Dravid Madam, for being the 3 big pillars for us in all that we had to do. And of course, Dr. Shilpi Sood, the immediate past secretary, Nishad Chimote, immediate past joint secretary, Dr. Chaitanya Shembekar sir, as the treasurer, and all our executive committee members, Dr. Charu, Dr. Kalidas, Dr. Nidhi Chandak, Dr. Amok, Dr. Riju, Dr. Megha Jain, and Mr. Rakesh Sahare. So thank you so much for being making our tenure so wonderful by all the contributions that you all have made. So, I mean, just thanks is not a word, but then that is all at the moment that we can give. Hope to have a great party, Sushma Madam, together.
Sure.
And of course, I cannot thank enough our constant partners, Corona Remedies Limited, Private Limited. They have been so forthcoming in whatever we had to do. All the time at the last moment, like today, we had forgotten to mention in the flyer, we had forgotten to mention Dr. Pankaj Talwar, and we missed the photograph. But today, in spite of being a holiday, Saturday off for them, and no office, no proper computers and everything available, yet Mr. Piyush, he took care that the things were rectified and we had the updated flyer in time today. So thank you so much. all the team members of Corona, all the time for all webinars, we have had different people and we had wonderful experiences. So Mr. Vinod Taivade and your team of Corona, thank you so much for being with us all the time. And last but not the least, the epitome of love, care, passion, not just for hysteroscopy, for ART in general. And I must say, she is like a motherly figure for us. So not hysteroscopy, not ART, as a human being, she's such a wonderful person. I must say I have learned a lot. And I mean, yet I would say I have imbibed probably only 1%, because it is difficult to have a person like her who just manages everything with a smile. I mean, people like us get hyper and anxious, but she's so cool as a cucumber, as they say. So thank you so much, madam, for me, you have been a personal guiding light, personally as well as professionally. Thank you so much. And she is the queen of heart, really, who plays all her master strokes with a scope in hand and love in her heart. And she is a multifaceted personality. She has authored several books on hysteroscopy. Not just hysteroscopy, she has authored several books related to literature as well. Somehow I could not manage to get the covers of those books. But lately we have she was so good enough to include me also in her endeavor. So we have come out with this book on IVF as well. I just hope that everyone benefits from this book, because we have tried to compile wonderful chapters from eminent personalities in the field. So Dr. Sushma, one more big feather to your cap with this book on IVF. So, and thanks to you specially for giving me an opportunity to be a co-editor along with you. Thank you so much. So last but not the least, this loving hand, now warm and capable of earnest grasping and facilitating life. Oh, wow, hysteroscopy. Everything you need is now closer to you. Just because we bring so many people, just because Sushma madam has brought such international figures from the field of hysteroscopy, everything seems so close. And hysteros, wonder, originates in the womb. So we have all wonderful people here who are dealing with hysteroscopy, and it is a miracle that is happening each day under your able hands. Thank you all for being a part of our lives, of being a part of this field and enriching it every day. Thank you so much. And with that, thank you so much, one and all. I mean, it is a time for celebration, a virtual Valentine cake, a virtual tenure cake for all of us. And I'm sure Sushma madam will give us a party soon.
Sure, sure. And we'll have a good photograph also. Dr. Sergio is there. So
Yes.
we'll have one good photograph. And it was Bindu as usual amazing. B for brilliant, E for intelligent, N for really noble, D for dazzling, and U for unstoppable.
Thank you so much. Thank you so much. So much to learn from you, ma'am. Let us see.
Yeah. We'll have one. Very nice.
Thank you. Thank you so much.
But
Dr.
just wait
Sergio,
for 1 minute.
I mean, I not being related directly to hysteroscopy as such, but then I have heard all your lectures and I really admire you and really, I mean, respect you a lot for the kind of the body of work that you have done, and yet so humble and so good in everything, the way you give your lectures. I mean, I'm really impressed and I really adore you for what you are, sir. It is wonderful. It has been a wonderful journey knowing you right from all the webinars that we have been able to witness with you. Thank you so much.
Thank you. Piyush, just have a good photograph. Can you just stop sharing so we'll have a good photograph?
Yeah, sorry, I forgot.
Yes. Piyush?
Yes, ma'am, I'm here.
Yeah. Okay, good to see you on screen, Piyush.
Yes. Vasu sir was supposed to be there.
Yeah,
na?
Vasu, Mr. Vasu also, yes.
Mr. Vasu is there?
Yes. I don't think he's there.
He promised me that he will be there.
Okay.
Actually, we had a function in our office also, so everybody is busy there.
Okay.
Yes, ma'am. I took the picture, ma'am.
Okay, thank you. Thank you, Dr. Sajio, because you were the for the opening ceremony and the closing also. That's why I wanted you to be here. Yeah. Thank you very much.
Thank you. Parul, can you play something for us on this piano?
Parul, you are with your cute Valentine is there.
Yeah, so
Yes.
something that he can play for us.
You want to play some synthesizers? No.
Oh,
Not a
okay.
lucky day for us today.
Yeah.
Play when somebody's.
Okay, thank you.
Okay.
Thank you so much.
Thank you,
Yeah.
Bindu madam.
Bye.
Thank you,
Dr.
Sushma madam.
Dipali.
Wonderful webinar.
Thank you. Thank you.
Bye.
Bye bye.
Thank you.